who really jumped at the opportunity to showcase the research they've done. And just to let you know that what you will witness here today is but a snapshot of what we have to offer by way of research within the Ministry of Health. You will be treated to 10 presentations by the following persons: Dr. Abby Harrison, Dr. Ingrid Buffon, Dr. Dorothea Hazel Blake, Ms. Gwethlyn West, Dr. Keneal Chrysostom, Ms. Ashley Williams, Mrs. Nadine Jubri, Dr. Paquita Watson-Jones, Dr. Tiffany Skerritt, and Dr. Shara Greenaway Jubri. The presentations have been divided into 3 themes: 1, disease management; 2, client behaviors and perceptions; and 3, disease and risk factor prevalence. So we will begin this morning with the theme disease management, and under that theme there are 3 presentations. At 10:30 a.m. we will take a short break and recommence at 10:50 a.m. with 4 presentations under the theme client behaviors and perceptions. Those presentations will be wrapped up by 12:50 p.m., at which time we will break for lunch and resume at 2 p.m. to conclude with 4 presentations on disease and risk factor prevalence. Now, each presenter, has been given a maximum of 20 minutes to share their research project. And this will be followed by 10 minutes for discussion and question and answer. You, our audience, you're therefore asked to pay close attention to the presentations, particularly those that pique your interest. Jot your burning questions down and save them until that 10-minute allocation for discussion. If you are joining us virtually, you may post a question in the comment section, and I will aim to have those answered, time permitted. Now that we understand the flow of the day a little bit better, please allow me to introduce the first 3 presenters in the order in which they will appear. Once again, our first 3 presentations collectively fall under the theme disease management. First to the lectern this morning will be Dr. Abby Harrison. She's a senior scientist within the UK Health Security Agency, providing data management and surveillance services to the overseas territories. She is currently performing epidemiological duties to us here in Montserrat. Dr. Harrison will be followed by a pre-recorded presentation by Dr. Ingrid Buffon. Dr. Buffon is a local physician with a successful private practice. She specializes in critical care of patients and is a well-known advocate for health and the improvement of health care on the island. Closing our first segment will be Dr. Dorothea Hazel Blake. Dr. Hazel Blake is the Director of Primary Health Care. With the ultimate aim of preventing disease, Dr. Hazel Blake ensures that the residents of Montserrat have access to a basic package of services needed to maintain good health. Presenters, you're reminded that you have a maximum of 20 minutes for your presentation. I will be seated right at the front, and you can keep your eye on me. I'll give you a little finger up at the 15-minute mark to indicate that you should wrap up. And with that, I will now invite Dr. Harrison to the front, and please give her your kind attention. Before I leave, though, one reminder, these devices, if we can please put them all on silent or vibrate for the duration of the day, that would be really helpful. Dr. Harrison?
Hi everybody, so today I'm going to talk about how we can use ICD-10 codes to monitor disease trends in medical admissions in Montserrat. So before I delve into the specifics, I want to provide some background context for the population that we're dealing with. So the population of Montserrat has actually decreased in recent years. From 2011 to 2022, we've actually seen a 12% decrease in our population. The age distribution of the population actually skews towards older age groups, with the majority of the population now being over the age of 40. Interestingly, the age dependency ratio has also increased from 47.1 in 2011 to 53 in 2022. So this indicates that the proportion of the population that is too young or too old to work has now increased relative to our working age population. This could have implications for the sustainability of social programs, the economy, and also our healthcare. It's also important to note that the birth rate is lower presently than the death rate. Although these figures are small, they can have implications for our healthcare system, particularly as the population continues to age. Okay, so I'm just going to give a bit of context about some of the public health challenges that Montserrat faces. So Montserrat is a publicly funded healthcare system which is managed by MHS. Our healthcare system includes 1 hospital, 4 community clinics, dental facilities, and flying specialisms. One of the biggest challenges faced is limited access to specialised medical care, meaning that patients will often have to travel to larger healthcare centres outside of the island, which can be costly and time-consuming, and can also put a further strain on the healthcare services on island. Additionally, health professionals in Montserrat might seek opportunities in other countries, which can also lead to a shortage of our workforce. Another major health challenge in Montserrat is the high prevalence of non-communicable diseases. A recent household prevalence survey highlights this issue. By understanding the changes in population demographics and resource challenges, we can better tailor our healthcare services and programs to meet the needs of Montserrat's community. Monitoring disease trends is an essential part of this process. It allows us to identify areas of concern and allocate resources effectively. We've been exploring ways to monitor hospital admissions and use this data to help inform policies and programs. By understanding trends in hospital admissions and how this is changing over time, we have a better idea of disease prevalence and how we can allocate resources more efficiently in the future. Okay, so before I go into the specifics of what has been done, I want to give a brief history about medical classification and what is an ICD code. So medical classification has a long history, with a French physician developing a system to categorize diseases into broad 10 categories back in the 18th century. Over time, various systems have been developed to categorize sickness and mortality. And today, the International Classification of Diseases is used worldwide as a standard classification and coding system. This allows for accurate diagnosis. In Montserrat, we use ICD-10 codes to classify all medical admissions in a hospital. This allows us to easily identify and track specific diseases and conditions, and gives us the opportunity to analyze trends in hospitalization over time. By mapping admissions data to disease groups using ICD-10 codes, we can gain insights into hospital utilization, specific diseases and conditions that are most prevalent in our population. This information can be used to inform allocation for resources and healthcare services. In the following slides, I'm going to explore how I've used ICD-10 codes to map admission data to disease groups and look at hospital trends over the past 10 years in Montserrat. Okay, so I'm just going to give a brief overview of how an ICD-10 code is structured. So the structure is hierarchical and consists of chapters, blocks, and categories. So clinicians or persons interested in understanding what a disease code represents could manually map ICD-10 codes to these diseases using a book. The problem with this is that it's quite manual and time-consuming, and it also can be prone to human error. To address this issue, I developed a computational script that will take the ICD-10 codes found in the admissions records and map these to disease group categories. This allows us to map thousands of records instantly to different levels of granularity, and explains and summarizes these groups in a natural language, which is easy to understand and makes us able to analyze the data. So what did we do? So this script that I developed was used to map all of the proximal ICD-10 codes. So this is the primary reason for admission across a 10-year period, so from 2011 to 2021 at Glendon Hospital. The information that we had in the medical records included age group, sex, ID, date of admission, date of discharge, and of course the ICD code. The objective was to review the records, describe the demographic and clinical characteristics of patients admitted, hopefully to ascertain the impact on healthcare system and understand utilization patterns over the last 10 years. So what did we find? So we had a total of 6,033 admissions, which represented 3,200 individuals. So we had quite a number of readmissions. Of these admissions, 54% were females and 45% of males. Our age, unsurprisingly, ranged from newborn right up to 109 years old. We saw that the length of stay ranged from 0 to 243 days, with an overall mean stay of about 5.9 days. Okay, So the first thing I was interested in was what patient demographics or what groups do we see utilising hospital bed space the most in Montserrat. Unsurprisingly, those in the 56 and above age group take up the majority of bed space. What this graph is showing is the total number of days spent in bed for each age group over each year. What we can see is this trend is slowly creeping upwards, so we are seeing bed utilisation increased in recent years, although we did see a dip in 2020, which is most likely due to the impact of COVID. Then when we look at length of stay by age and also sex, unsurprisingly, we can see that we have some residents in Montserrat that are spending an incredibly long time at hospital. And again, this trend is, we can see from this trend that as patients age, they're typically spending longer in hospital, which is unsurprising. But to be able to see these numbers, we can see that this trend is also increasing over time, so we're likely to see an increase in this. Okay, so then if we look at the most frequent reasons for hospitalisation in Montserrat, pregnancy, childbirth, and the periprurium it was the highest ranking disease admission category, with 816 encounters over the 10-year period. For this category, the majority of which, however, were linked to an uncomplicated full-term delivery. Then, if we look at diseases of the circulatory system, this was the second ranking reason for admission, with hypertension higher than all other categories within this group. Finally, if we look at diabetes-related admissions or endocrine-related metabolic diseases, unsurprisingly, proximal diabetes accounted for 8.3% of all admissions over the period studied. Then if we look at admission counts over time, what this chart is showing is where you've got darker colours, that's an increased count, you've got a high count. So what we can see is that for the majority of our disease groups, the pattern is quite stable. However, if we look at neoplasms in 2021, we've got quite an increase on the previous years, which I'll talk about in a moment. So these diseases are grouped to show how the admission rates for different categories have changed over time, and it helps us understand if there's been any change in prevalence. The years 2020 and 21 we can see have been impacted by COVID because our admission rates for all categories, bar diseases of the circulatory system, really dropped. So now if we look at length of stay by disease categories, so we might have noticed in the previous slide that some categories, such as mental and behavioural disorders, have quite a low admission count, but regardless of this, the time actually spent in hospital for these diseases is quite significant. In fact, it's the highest of any disease count. Okay, and then I looked at admissions by sex. So we saw that females have a lower median age of admission, so 48 versus 57 for males. When I looked at specific diseases, females were more likely to be hospitalised due to diseases of the blood, so things like anemia, endocrine and nutritional diseases, so a higher likelihood to be hospitalised with diabetes, and diseases of the genitourinary system. The number of males that were admitted due to external causes, or what we'd refer to as accidents, was much higher than that of females. Also, we saw an increase in males in respiratory and digestive disorders. Statistical analysis identified that out of all of our highest ranked medical conditions, 4 out of the 20 showed a difference between males and females in terms of presentation at hospital. So to look at this a little bit further, in general, for most conditions, there is no difference between the sexes. However, for diseases of the urinary system, female patients have a higher utilisation rate. However, males have a longer length of stay. Then if we look at neoplasms, as I mentioned in the previous slide, in 2021, we had an increase in the number of cancer-related admissions. This trend is mirrored in both males and females. And this table displays the type of neoplasms and their corresponding frequency, percentage, and distribution among males and females in Montserrat. For females, the most common type of cancer identified was breast, followed by colon, and then cervix. For males, the top 3 neoplasms were prostate, colon, bronchus, and lung. The high number of admissions for malignancies in both the colon and in males and females is quite noteworthy, as colon cancers can be typically treated if detected early. The number of admissions that we see here may reflect the prevalence in the population, or perhaps it's differences in screening and diagnostic practices. Therefore, it's important to ensure that adequate screening and early detection measures are in place to help reduce the burden of these subgroups. So to conclude, I think that this data shows that there is a need perhaps for more preventative care. We can see that there is an aging population, and this is reflected in medical admissions with a higher prevalence of chronic conditions such as cardiovascular disease, diabetes, and respiratory illnesses. This hospital admission data underscores the need for more preventative care and perhaps more community-based resources to help manage these chronic conditions and prevent acute illnesses and presentation at hospital. Adequate screening and early detection measures, as we know, can also help reduce the burden of neoplasm-related hospital admissions. Thank you. Does anybody have any questions?
So there is a roving microphone going around. If you have any questions, now will be the time to indicate, and we will bring the microphone to you. So we're now open for any questions, any comments, discussion for the next 10 minutes.
There's a question.
Thank you very much, Dr. Harrison. I think that was an excellent presentation. Thank you for showing us the work that you've done, looking at a 10-year perspective in terms of the trend of hospital utilization. I have a question specific to mental health. I noticed that the length of stay was significant for mental health. Are you able to give just a little bit more information in terms of what you found in mental health when you did this study? I think that would be useful for...
Yeah, of course. Let me just pull up the slide, and then I can talk through it in a little bit more detail. So what this table is showing is the absolute counts for admissions for each disease group. What we can see for mental and behavioural disorders, the numbers are relatively low. However, when we look at the length of stay is the highest for this disease group. Where is it? And I haven't got the data in the slides at the moment, but I did look at how this had changed pre and post-COVID. So the length of stay for mental and behavioural disorders increased during the COVID period, which might be an indication of more severe outcome, perhaps. It's something that I think we can see evidence of, but we'd need to investigate further and also look at utilisation in community settings for mental health services and see how those are impacted too.
Good morning, and thank you, Dr. Harrison. That was a really good presentation. I would, it's just a comment, not a question, just to say that listening to your presentation, I think that we have a lot of work to do in terms of prevention and to reduce hospitalization of our patients. As we can see, healthcare is very costly, and the fact that we have to be medevacing our people overseas quite a bit, I think that we have some work to do, especially on screening and in terms of prevention, especially of our non-communicable diseases, like for cancers, and more education talks, I suppose, especially for our diabetics and hypertensive patients. As we can see, those are the ones who really come into hospital more, and we get more readmissions of those persons. So bringing this research to us and highlighting, not that we don't know, but highlighting those those key areas, I think it is something that we have to really be paying more attention to. So thank you for your presentation.
Thank you.
Yes, I share the same sentiments. Very good presentation. I realized that for the cancers, they would have practically doubled. And I was just wondering if you were able to, during your data collection, to see, if persons had the necessary checks like the PSAs leading up to maybe the diagnosis of the cancer, or is it that when they came onto the hospital ward, that's when they realized that based on the symptoms? So it'll be good to look to see, the lead up in terms of what tests were done or what interventions were made, if any, and so forth. So, presentation, doc. Thank you, doc. Thank you.
Thank you. No, I think that comment is it's really important. Maybe that this might open up an avenue to explore this a little bit further. And I completely agree. It'd be used to look at this cohort and see what decisions were made leading up. Were they presenting previously? Were they offered screening services? And just explore that a little bit further.
Any other questions?
Good morning. A very good presentation. I was wondering, is this data that you presented this morning, is it being used to inform future care by the ministry? Have they been utilizing the information here to guide their policies?
So I'm not sure as of yet. This is sort of fresh off the press in terms of the analysis, but I work quite closely with the CMO here, and I think we'll probably sit down together and see what are the next steps for us with these findings. So, yeah.
Any other questions? Okay, I have a question, or maybe more of a comment. The planned introduction of our health information system, I think, will add to our arsenal in a particular way to perhaps deal with what Kim raised, because in primary health care, we'll be able to flag when persons have not had a particular screening test. For example, every time a female between a certain age comes in to see the doctor, it will flag that this person, for instance, has not had a PAPS test result, certainly in the system, since X time. So the opportunity to then suggest screening and encourage screening will be there. Similarly, if it's a male, as they enter the room and have been, the initial assessment by the doctor, the system actually flags that these are some of the screening that should be done. Not to say that we're not aware of this, but when you have it in front of your face throughout the consultation process, it does increase the likelihood that none of these things will be missed. And so we are excited about the implementation of the health information system, which should commence very shortly.
Yeah. One of the, I think, will be a great benefit of having the health information system is, as you said, being able to identify patients that are eligible for screening services but might not usually engage, and being able to push them into utilization of the services, because something we can see in the data, and it is reflected in both cancer admissions and diabetic-related admissions, is that males typically present later than females, and when they do present, they're spending a longer time in hospital, which is probably an indication that they're not presenting early. They're waiting until their conditions are quite acute before they're admitted to hospital. So if we have that ability to target them earlier, that would be, I think, have great outcomes for everybody. So, okay, is there any more questions?
Going. All right, thank you, Abby.
Okay, thanks everyone. Bye.
Okay, so I think it's fair to say that we are out the gates with a bang. Y'all agree? Yes. So our next presentation will be by Dr. Ingrid Buffong. She really intended to be here with us this morning, but she cannot, owing to an emergency. However, we are grateful for technology, which has allowed her to pre-record her presentation for us. Unfortunately, that means that she will not be available to lead the discussion after. However, the floor will remain open should we want to have discourse on the topic that is presented. And Dr. Buffong's presentation is titled The Management of Critically Ill Patients in Montserrat.
Hello, everybody. This is a presentation called The Management of Critically Ill Patients on Montserrat. It is the condensed version of a master's dissertation done in 2018 under the Chevening program, and it was presented to the Caribbean Public Health Agency conference in 2019. The aims of this study were to assess the care of critically ill patients at Glendon Hospital, Montserrat during the admission on which they died, to assign care delivery scores to each system assessed and preventable death scores to each case in order to assist in describing care, and to highlight aspects of care that are inadequate and areas in need of improvement, and based on these findings to make recommendations for changes that would improve the quality of care provided to critically ill patients locally. Hypothesis. It was thought that the lack of local availability of CT scanning, and at the time the absence of a critical care bed and inadequate certification in acute care courses were significant problems. It was felt that these particular features of local care for critically ill patients were likely to negatively affect the quality of care delivered to the study group. The literature. Hogan et al. In 2012 published a case record review. They assessed the quality and safety of care provided to 1,000 patients in 10 acute hospitals in the UK in 2009 during the admission on which they died. They noted that studying deaths is likely to help to identify a wide range of problems in care. Zeggers et al. In 2009 in the Netherlands looked at deceased patients' notes, as did Kalbaker et al. In Canada in 2012. Dijkema et al. In 2012 proposed a project for evaluating a minimal mortality in the ICU after extracting data from the notes of deceased patients. They stated that survival is the most important outcome of critical care, and if we could analyze the causes of death, we might identify problems for improvement. Methodology. The study period was from January 2013 to February 2018, during which there were 2,966 admissions and 215 deaths. Due to factors related to conditions of storage, locating the notes of deceased patients proved problematic, and only 75 of the 215 notes fitting the name and date of birth were found, and of these 75, only 34 were appropriate for use and were used in data extraction. Inclusion and exclusion criteria. For a patient's notes to be included in the study, the events surrounding the death of the patient in hospital had to be recorded in the notes. The notes of both doctors and nurses needed to be present, and patients of all ages and all specialities were included. Exclusion criteria included patients who were already at the end of life because of end-stage diseases, in particular metastatic carcinoma, were excluded. So this was a retrospective audit of patients' notes. Detailed information was captured in the notes about the care of each patient, and the patient's care by system was recorded against the standard of care expected for that particular patient. Care delivery scores. Care delivery scores were calculated for each affected system or separately for sepsis for every patient. 1 point was given to each intervention or investigation required. The care delivery score for each system was calculated as follows: points for items received which were required over points for items which were required times 100, and that would give the care delivery score for each system in a case. The care delivery score for each system answers the question, what percentage of the investigations or interventions for the affected system which were needed did the patient actually receive? Preventable death scores. Preventable death scores for each case were calculated as the mean care delivery score for the systems in each case. Cases scoring over 50% were recorded as deaths which were not preventable. That is, there was not a lot more that could have been done for the patient. Cases scoring less than 50% were recorded as preventable deaths. The preventable death score answers the question, what was the overall care like for the patient? Results, preventable death scores. 62% of deaths were calculated to be preventable deaths, and this increased to 85% for patients who were under the age of 74 years. The most common preventable death score was 40 to 49%. Failure to perform CT brain was the most common deficiency of care for neurological cases. 62% of patients requiring CT head were under 70 years old. In septic patients, the lack of blood cultures, no arterial blood gas sampling, no CVP or mean arterial pressure monitoring, and no source cultures were common. CPR was performed in only 15% of cases in the study. No patients had early warning scores. No patients had care bundles. However, a few patients had pressure sore prevention checklists. In the cardiovascular system, the most common deficiencies in care were failure to medevac patients for coronary care, failure to use inotropes, lack of invasive monitoring, and serial ECGs not being performed. In the renal system, deficiencies in care included the inability of patients to receive renal replacement therapy when indicated and inappropriate medications being used for renal patients. In the respiratory system, the most common deficiencies in care were lack of arterial blood gas sampling and lack of invasive ventilation when necessary. This slide shows preventable deaths versus non-preventable deaths and the age groups involved. This slide shows preventable deaths versus non-preventable deaths, looking at systems showing significant issues with the cardiovascular system, renal patients, and with patients with neurological problems and sepsis. Discussion points. Most deceased patients in the study had preventable death scores of less than 50%. That's 62% of patients in the study. This included some persons under the age of 60 years old. And the message here is that not all young critically ill patients will make it off island for care in their time of need. In patients with musculoskeletal problems, 3 of them had neck of femur fractures and 1 had an acetabular fracture. Delays in definitive early care led to infected pressure sores, fat embolism, and pulmonary embolism. And the message here is the guidelines suggest early definitive care within 24 or 48 hours for fixing fractures that could increase the risk of complications. In the respiratory system, most patients were over 80 years old, and this might suggest some vigilance in managing younger patients with acute respiratory problems. So it's only the older ones who perhaps would have been perceived as not likely to benefit from more advanced care. Younger patients with respiratory problems may have survived and thus would not have made it into a mortality study, whereas the older, frailer patients would have. Looking at the cardiovascular system, a younger patient group had the cardiovascular system affected in their critical illness and had lower scores suggesting inadequate care for these patients. The creation of protocols for certain conditions and close attention to patients whose survival may depend on medical evacuation to a coronary care unit will improve care. In the renal system, most patients were over 70 years old. Case review suggested that socioeconomic differences were at play in accessing renal replacement therapy. The high prevalence rates of diabetes and hypertension have been well noted to increase the need for renal replacement therapy, particularly in older patients, and we've known this since the 1990s. And the message here really is that Caribbean countries have had 20 plus years to take note of this phenomenon, and we should really be more prepared. The vast majority of patients with end-stage renal disease in our region requiring renal replacement therapy, dialysis, are patients who are diabetic and hypertensive who've had this for a long time. So we really need to think about how we're going to care for these patients in the future. Looking at the neurological system, the lack of CT brain was the most common deficiency in care. Only 1 of the 6 patients in the study requiring CT brain received it. Useful discussions with appropriate neurology or neurosurgical teams and modern interventions like thrombectomy or thrombolysis and acute stroke all require CT brain results. Stroke guidelines suggest we do CT brain urgently within an hour of arriving at hospital. And thankfully, we shall soon be doing this. CPR was a problem. Inadequate numbers of patients in the study received CPR at the point of their cardiac arrest. This not only highlights suboptimal care at the time of cardiac arrest, but really questions the general standard of care in the peri-arrest period. If nobody bothered to do CPR, what were we doing before cardiac arrest actually occurred? The absence of do not resuscitate orders in the notes requires attention. So at the time, no patient's notes had do not resuscitate orders, and none of these patients with a lack of do not resuscitate orders received CPR. So medical staff have a duty of care to resuscitate patients unless there's a prior agreement that the patient is unlikely to benefit. And decisions about CPR really must take place well before cardiac arrest, and they should be documented in the patient's notes. Some of the strengths of the study were that the details of care were assessed through a thorough review of the case notes of the patient, and that despite the small sample size, the small population of Montserrat makes this sort of study more relevant or generalizable locally than if a small study was performed on a large population. The small sample size of the total population and the features of the local healthcare system described certainly suggest that there could be a potential relationship between the features and the outcomes. We can look at study limitations. It was not possible to compare the results of this study with other studies as the method was original. The validity of the method as a way of assessing preventable deaths and quality of care has not been previously assessed to compare. That items in the study perhaps could not be weighted equally. Does one weight the need for inotropes with the requirement for serial ECGs? They could potentially be weighted differently. The availability of data in the study was poor, so only a small sample size was used. The study would be very labor intensive if the sample was larger. So if we managed to get 500 patients' notes that were all appropriate, it would be a struggle for one person to go through all of these case notes. Looking at bias, this study potentially could have the risk of the Pygmalion effect, observer expectancy, in which the author hypothesizes that the outcomes will be poor and is influenced by this in data collection. And I think the most obvious one is selection bias. Assessing mortality cases results in the selection of the very worst cases and omits the well-managed cases which survived. So all the patients in this study were patients who died. It does not assess the care of all the patients who were managed beautifully and did very well. And in conclusion, the management of critically ill patients at the end of this study was thought to be in need of attention, particularly as not all patients were going to make it off island when critically ill. Some patients would have been medevaced from the casualty department, some patients would have been admitted to the ward and managed to be sent off island for critical care, but not all patients were going to make it off island. And so I think at the time it was really important that we were able to look after our patients in a better way in hospital. Recommendations. Attention to the peri-arrest period. So it was felt on going through a lot of the case notes that it was pretty obvious that the patient was going to arrest at some point as the vital signs became unstable. The patient was obviously deteriorating, and some of the interventions that could have been done to prevent cardiac arrest and death were not done. So the peri-arrest period is the period before the patient actually arrests, which is a really important time in the life of the patient. Not all patients survive CPR, even when it's done properly, so it's important that they don't get to that point of arresting. And then, of course, CPR for all patients who did not have do not attempt resuscitation orders in the notes. It was felt that Montserrat needed to have an intensive care bed or a high dependency bed for its hospital. So this study was done in 2018, and of course, thankfully in 2019, the government of Montserrat realized the need for this. And then 2020, 2021 came along, and we got more critical care beds thanks to COVID, to the pandemic. It was felt also that we needed a commitment to training and to practice and to train the trainer programs to ensure a high standard of care and sustainability. So some of the important courses that were thought could be useful were the Fundamental Critical Care Support course by the Society of Critical Care Medicine, Advanced Trauma Life Support, Advanced Cardiac Life Support, and Pediatric Advanced Life Support. It was also felt that focusing on training trainers would make ongoing continued education and certification in these areas sustainable. And of course, CT scanning, we can play the harp on this one, but I think the message has reached home, and thankfully, hopefully this year we shall be scanning patients, maybe by the end of the year, and being able to follow guidelines without the cost, inconvenience, and risk of travel for unwell patients. Other ways of maintaining quality of care, a culture of self-audit and research is essential. The implementation of early warning scores and care bundles would be really useful. And having protocols for specific groups of patients, such as those requiring coronary care, would make things work more smoothly and will make sure that our patients who are infarcting are not sitting on the ward, but are being medevaced safely to a coronary care unit. We really need to be thinking about dialysis. We need to admit to the present and future need for dialysis, explore ways of securing funding for a dialysis project locally, and ensure that socioeconomic status does not play a part in deciding who receives it and who does not. It was felt for a study like this to be done in the future that we need to address the storage and accessibility of medical notes of deceased patients, because they're needed for legal reasons, but also for research purposes. It was felt for a study like this to be done in the future that we need to address the storage and accessibility of medical notes of deceased patients, because they're needed for legal reasons, but also for research purposes. And in closing, the proverb that states that the journey of 1,000 miles begins with one single step, and many steps have since been taken since 2018. I want to thank those who work so hard in health, those who are passionate about healthcare, and those who care about outcomes and improving the quality of the service that we provide for patients locally.
So as I previously mentioned, Dr. Buffon is not able to join us today. However, the floor is open for discussion. Who would like to get the ball rolling? Just show by indication of your hand and the microphone will come to you. I see a hand over that way.
Well, it was a good presentation, and I just want to make mention that based on observation, that in recent years, we've actually started to address some of the things that could improve care for the patients. For me, in particular, I would have taken part in the recent training for CPR. So I can say that, in general, from my perspective, that we're taking steps in the right direction to improve. And I know that, CT scanning is on the way and so forth. So we're taking the step in the right direction. Yeah.
So this might be a good opportunity. I don't really want to put anyone on the spot, but it might be a good opportunity for us to take in so that those we in the room might know, owing to the fact that we are all in health, but it would be a good opportunity to let the public know what steps are being taken to improve our management of critically ill persons in Montserrat.
I guess putting me on the spot, Chief Medical Officer.
I apologize.
And that's perfectly fine. So yes, we have made several strides since this study was done. I was there when Dr. Buffon presented this at CAFA, their research conference, a few years ago. And so as CMO, at that time, and I'm still CMO now, we would have made some plans to implement certain things. So I will address as I recall as she presented them. So in terms of, I'll address the issue of coronary syndrome or heart attacks. I'll put it plain so that everybody could understand. We developed a chest pain protocol, and that was developed by initially one of our medical officers. We reviewed it with a Montserratian cardiologist. And what is left to be done now is to implement it. So training of the staff, making sure that we have the available medications on island, and that we set up the proper referral pathways. So we have engaged medical centers overseas for acute coronary care. That's usually the French islands, because next door in Antigua, they still don't have a cath lab, as I would put it, where you can actually do the intervention to remove the clot, etc., for a heart attack, right? So that is the avenue that we use. It is an expensive avenue, and so we are also taking steps to address that. That is a fairly long pathway because, of course, several governments are involved in that, and you have to negotiate and develop MOUs, etc. But at the same time, just to say that we do have a pathway, but it needs improvement, and there's further training that is required for that. Of course, for neurological issues, the CT scan is coming, and we expect to launch that service towards the end of the year. Several things needed for that too, training, and also you need to engage a radiologist. We want to make sure that what we are producing in terms of the reports that are generated and that you have accurate interpretation of the images that you produce. So that should be on stream towards the end of the year. Other things, the high dependency units, we actually developed that before COVID. And then, of course, we had additional equipment and furniture like beds and so on implemented because of COVID. With our anesthetist, she was here. Oh, Dr. Garcia. Yes, we've done a lot of work in terms of managing critically ill patients. We have protocols in place. So admission criteria for a high dependency unit, that has been in place since 2019. So that, again, is something that we would have done. Luckily, too, the anesthetist is strategically placed close to the hospital. So the medical officers, they can quickly call for that extra help. And in larger centers, they benefit from having more teams, more specialists available to them. You have on-call teams specifically to respond to persons who arrest and that sort of thing. We don't have that liberty here. So I think we made a huge, huge step in terms of training. I think it was over 70 persons in basic life support. And then, of course, all the doctors on island, including the private sector, being trained in advanced cardiac life support. For the basic life support, we thought that it was important to expose all levels of health staff. So the orderlies, there were some maids as well, and of course the nurses. And we extended it to the general public because you don't have to be a medical professional to learn basic life support. So we thought that it was important to include everyone, or as many people as we could possibly include, so that you don't have to wait until the ambulance drivers arrive or whoever to start offering CPR. If you know the basic tenets of basic life support, you can initiate that until medical professionals arrive. So those are some of the things that we have implemented from the Ministry of Health and Social Services standpoint. I think I'll stop there.
I have a question that, I don't know, maybe it might sound silly. Do not resuscitate orders. That came up here. And that's something I've only ever seen on television.
Yes, sorry.
Is that something that's practiced in Montserrat or even in the region?
What we've done in the region, yes. We've discussed it at the medical level, as in the medical doctors. We have a draft in place, but that has a legal implication.
That's why I
So
was
it has to
thinking.
go through a process before we can actually implement it.
Okay,
So
thank
just
you.
to say, yes, thank you for bringing that up. We have actually started addressing that.
Okay. Any other comments, questions from the audience? I have one over here to the front, Dr. Coward.
Thank you. It's just some reflections, really, from my notes. I thought it was excellent presentation from Dr. Buffon. It seemed to cover, it's very comprehensive. She even pointed out a limitation. One of those limitations was on a comparator, because I would have, she was given a lot of, she was given the percentage of the preventable deaths. And I was thinking it would have been good at that time to have an idea about that percentage in other countries, perhaps Antigua or Barbados, just to compare and contrast to see where we are on that. Also, in terms of, people have said already, there's some quick wins that we could do because it was realistic, it wasn't pessimistic, but towards the end it got optimistic, and I heard what the CMO is saying, but we're starting from, it seems, not a low base, but there's a lot of work to be done. You can see in Montserrat, and that's not just dependent on funding, although some of it is. It's about the scanner is coming. So some quick wins is the scanner and the CPR. I did wonder, in terms of, I did wonder how is it? Because when she talked about the lack of CPR, that was in hospital, so she was talking about medical staff, wasn't she? Am I right?
I believe so.
Yeah. So I wondered how that can come about, that at the time somebody has a heart attack, that no CPR is automatically done. That's for other people to answer. I wonder how that could come about, no CPR at the point of cardiac arrest. And it was essentially an outcomes research based on clinical outcomes, but maybe it's another research to have one based on more, because it was titled The Quality of Care. So I would have liked to have had some patient input in terms of compassion, sensitivity, and the care that they felt they received different from the clinical outcomes, if that makes sense. You know, how was their experience in hospital? How did they think they were taken care of? How well? I know that's probably a different study, but I would have liked to have seen it nonetheless. Okay, so that's about it. But I did think that 62% of preventable deaths seemed very high, and only 1 in 6 persons who needed a CT scan got it. And sort of reasons for that, I'm not sure. Not everybody was Medivac. There's reasons why people can go immediately and why persons have to wait until the next morning. So in essence, what they're saying is that if you live in Montserrat, you're at a higher risk of some, of some adverse outcomes. And I guess that relates to why a lot of people don't come back to Montserrat if they have a number of illnesses and they look at the healthcare system and said, well, we'll wait till they build up a bit before I come back. And the last thing, finally, there was mention of socio-economic difference playing a part. How does that figure? I wondered how did that come into it? Does anybody know what she was referring to?
No, unfortunately, no. We can ask her, the program is being recorded, so we do have opportunity to have some questions answered and shared with health staff at a later date. Just one point to note on the mention of the high percentage, because sitting at the front when I heard it, I almost, had an audible gasp. But we also have to appreciate that's a small sample size. And the small sample size leads to very skewed and high percentages. So what we would have really had to appreciate the figures more is exact figures, exact numbers. Because, for example, if we had 4 cardiac events and 2 people died, that's 50% of, whereas in a larger population, if they have 100 and 2 die, it's a much smaller percentage. So that's one of the challenges always when you're dealing with small populations. You get these really high percentage that give us almost a heart attack ourselves. Are there any other questions or concerns before we move on to our final presentation under the disease and management theme?
If I may, Dr. Buffon did describe near the end of the presentation, she spoke about selection bias. The study in itself is looking at dead people.
Yes.
It is looking at those who succumbed to their illness. So you start off at that point. Now, there's a perfectly legitimate study, but it does start with persons for whom the outcome was death. It would have been interesting, as she said, instead of that study design, to have a different approach where you looked at those who had succumbed to their illness, and you have that proportion who using the scoring technique she used, but in a comparative group of persons who also had renal issues, of persons who also had a cardiac event, and see what proportion of those over the same time period, stratified by age and sex similarly, and see what proportion of those persons survived. And then you would have had a more robust conversation to be had. But she did identify that as one of the weaknesses, so I give her credit for that. But all I'm saying is then that in this room, those of us who've heard that have an opportunity now to do the other study.
That is very true.
In time for next year.
And just to let you guys know, please, if you can save your questions from this presentation in particular, as we do not have Dr. Buffon here, it would be really great if we could collect those questions, present them to her, and maybe have a follow-up session, hopefully for the wide population as well, where we can get some of the answers to the burning questions that we had. We have one last comment.
Yes, one quick comment. I really want to address the renal disease and dialysis conversation, just especially because if we have the public listening. One of the presentations from today, so that's Dr. Chrysostom, will be presenting on the prevalence of renal disease in the clinic setting for persons presenting to our health centers. And this was a very important study, because before you can implement or try to justify implementing a new service, you need to have data to back you up. So it was very important for him to do that study. So you will see the outcome, you'll see what he found. And so we're going to be using that study to then build on it and, make the justification for implementing some services for renal disease. So I just wanted to make that comment.
And that point is absolutely a very critical one, and it's one of the reasons why this is just such a beautiful day. Oftentimes we have to rely on extrapolating data from international organizations or even in the region, but here we really have an opportunity where the vast majority of the research pieces that we have today were done here. They're of national importance. They're definitely what our population is saying to us, and that's really going to inform decision making on a beautiful day. So once again, thank you to those who conceptualized it and brought us together here today. So we will now go to our closing presentation for the first segment of the program, and I will invite Dr. Dorothea Hazel-Blake to come to the front and direct us.
Good morning, everyone, again. We're going to change topics, and we're going to talk about the school health program and some trends that are being observed that I think the time to act is now. Clearly, I do not know how to operate the thing. So very quickly, we'll give you a background, remind us of where we got the data from, how we analyze the data, and what some of our results are. And I note the term some. Now, the annual school health program, if you listen to the radio, even if you're not in health, you will hear from time to time, you used to hear the lab is closed because they'll be conducting school health, or the health centers are closed, there's school health. It is an opportunity to screen school-age children, and it's usually scheduled in the second term of the academic year. We look at 3 groups of children, 3 cohorts every year. So it is children who are just ending nursery who are about to go into primary school, so they're usually around 5 and 6. We also have the grade 6 students of the primary schools. So they're about to go into secondary school. And then the third group is the third formers of the Montserrat Secondary School. And all schools, so not just the government schools. So if there are the private schools, private nurseries, they're invited to take part. And of course, we seek parental permission. This is a quick look at the brochure that we have recently updated to share with parents so that hopefully they're making informed consent. So we don't just go out and grab their children and assess them, we seek their permission. So it can't see clearly, but it tells you how to prepare your child for school health. So it says to the parent, make sure you talk to your child, etc., so they understand what's going to happen. We do routine screening, so weight, height, blood pressure, and blood sugar. The nurses or the FNP will do a head-to-toe physical assessment, looking for certain things which could be a trigger to say an intervention is required. They go to the dental clinic where the dentist will do oral examination, and then the mental health team also is part of it, and there are interviews and discussions that take place as we remind the children, of course, age appropriate. So you may not speak to the 5 to 6-year-olds about certain topics, but you certainly, there's some stratification of what is said. Talk about the dangers of tobacco and alcohol use. Recently, we talked more about hand washing and had demonstrations. Talked to them about personal hygiene, various topics. So that, in a nutshell, is what the school health assessment is, and it is from this particular assessment over a period of time that we have found the data. Having completed the assessment, then you have to let the parent know what is the outcome. So each parent then usually gets a card, looks like this, with the information, your name of your child, blah, 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 and then the nurses will fill in the relevant information and make sure it gets back to the parent. It's not just us. We have to work along with the Ministry of Education because it's usually school time, and so they usually work with the team. We get access to the school buses in some instances to bring the children to the clinic. Some parents prefer to be present, so the parents are welcome to come along, but certainly the class teacher comes and they're there with us for the morning, and there's a schedule and everything flows. It can be quite challenging at times if you're not used to having scores of children running around St. John's Health Centre yard. It is quite an enlightening day for people like me who are not as comfortable around large groups of children. And we try to get the reports out to the parents within 2 weeks. And of course, if there are problems identified, they're encouraged to bring the child in to take up on a referral. So if they're referred to the pediatrician, to the nutritionist, to the mental health team, because of one of the findings, and that is also done. All right? So let me go back. Notice I said that there are lots of things that are done. So just wanted to clarify that this particular presentation is not going to tell you about everything that happened in school health, because there could be an entire presentation about, I don't know, the blood sugar findings. Are we finding diabetic children or pre-diabetic? It could be a whole thing about the mental health, because they do the moods and feelings questionnaires, and based on how the children respond to how they have felt in the last 2 weeks, that's a whole other intervention that may be required, which Mr. Babishile and his team will deal with. Sometimes they deal with it themselves, sometimes they're referrals to the education psychologist. So what we're going to focus on today is weight for height. Just wanted to make that clear. So again, other opportunities for further analysis of the data and more research. Oops, going in the wrong direction. So looking at the data for 2010 to 2022, that is the school health data for those years, each year the data would have been entered in an Excel spreadsheet. So they were reviewed for consistency, inconsistencies, and completeness. So for example, sometimes it may have typographical error, because you would see a primary school age child who, when you calculate the age based on the date of birth, he or she is 16, which, is not supposed to be. So we would have to go through, make sure that there were not some typos. We found a few of those, and because it's small, you go back to the source. So you go back to the public health nurse or something and say, okay, this particular child, could you verify the date of birth? And maybe there was a typo. Instead of 1975, it said 1985. All right? However, so you were corrected where possible, and you verified at source. There were 7 children for whom we could not verify that there was an error, and so those were excluded from the analysis. The exclusion criteria, there were children who did not fit the expected age group. So clearly those 7, if it was to do with the age group, in a few instances, there were children who repeated the grade. So they really didn't fit the age group. Maybe the child had a developmental or some sort of challenge, which made them, they kept them back for 3-4 years. So you had children with the 4 to 5-year-olds who was already 8 or 9. Then we did not, the child was assessed, but we did not include it in the analysis. And there were 1 or 2 for whom with key measurements that the height for some reason was just not entered into the database. So that was a clerical error. And when we went back to the source, it wasn't there. The child's name was there. Some of the assessments were done, but there were 1 or 2 that there was just no weight or height. Could be too, I could tell you from my own observation, some of these children do not want to stand on the scale. It's terrifying. Some of them, they look at it and for some reason they think it's a bad thing. And sometimes you don't want to traumatize the child further because there are other things. So if the child is looking quite normal, weight for height, you don't really press. You just leave them alone. All right. Quick reminder, the measurement used is the body mass index, which is a means of using the weight and height, and there is a formula that's used. Once the body mass index was calculated for each child, it was then mapped against a reference population that is used throughout the region. There are several ones, but we use the one I think that was recommended by what was then the Caribbean Food and Nutrition Institute, which later became merged into what is now the Caribbean Public Health Agency. Children above a particular percentile, so when you rank the children all by their weights, from the heaviest down to the lightest, those who were more than, above the 91st percentile were considered to be overweight. If you had reached above the 98th percentile, that was categorized as obese, and children below the 2nd percentile, which is at the other end, would be considered as underweight. That's just the initial assessment. Let me hasten to add, in some instances, based on the BMI and where they fall in the chart, they would be referred, and if the pediatrician makes that final call, because hope you don't mind I pick on you, if we have a parent who looks like my friend here at the far right, and the child is assessed as being underweight, and you walk into the clinician, the pediatrician, and they look at you, the child, and all the other parameters are healthy, you look at the mother, and the mother is also a very slender build, then perhaps it's not such a big, you don't expect the child to be any heavier, it may not be clinically important. So it's not an automatic thing. And similarly, some children, if they're on the borderline with being considered overweight, and you look at the rest of the family, not saying it's a good thing for them to keep going, but the reaction would be a little bit different. You just do some, gentle reminding, all right? All right, so the general findings. For the period that we just described, a total of 2,394 BMI measurements, or measurements from children were collected. You notice it talks about the number of children, but that's because some children had several measurements. Similar proportions were recorded. This is, I found it most important. Only 76% of the children were checked only once. You would think that, remember earlier I described, we see children at nursery school going into primary, we see them again at primary going into secondary, and then we see them again at third form. But for some reason, which we have to hypothesize about, many of the children in that data set were only seen once. It says to me that a lot of our children, you see them maybe, in the migrant populations. So you see them at nursery school, but by the time they get to primary school age level, the parents may have migrated with said child. So you don't get. Or sometimes you miss them and they come back. So only 46% of the children do we have data for in the 3 measurements, which can present a different type of opportunity. All right? And the biggest group, as I said, was nursery, which says the children are born here and then go off to other places. Overall, 1 in 4, 25% of the children assessed were overweight. And for me, I didn't make a big distinction between overweight or obese. At this point in time, they are not at what is considered a healthy weight. So that's 25% of our children. And if you look at the boys, if you separate them into boys and girls, there's no statistically significant difference between the two. That's when you lump them as an entire group. If you look at the individual years, there was a year in 2014 where only 6% of the boys were overweight. And then in 2022, 27% of them were overweight. So it ranges. It doesn't go in a straight up line, but that's the lowest. Similarly, the lowest percentage in the girls was 7.6%, and in 2011, the highest was 22%. So it varies by cohort, and it begs the question when you look at what we call birth cohorts, what happened in a particular year. Some children, or you look at a particular school and you think, what happened? This whole group started out healthy and it's going along. Weight by school age cohort. So again, I'm not sure why it's not this clear. This is saying nursery. If you look at all the nursery school children that we assessed, the green is what's considered healthy weight, underweight, and the proportion of them who are overweight or obese. Similarly, this is the primary school group. So these are the, 11 to 12-year-olds. The majority, yes, normal weight, healthy weight. The proportion looks a little bit larger. And these are the secondary school children. And this, again, just to remind you, this is the raw data before any intervention. Small numbers again, but just decided to see, all right, based on the addresses of the children, is there any difference, all right? This is Lookout, St. John's, Davie Hill, Salem, St. Peter's, Barzies, Alveston, Manjack, Judy Peace, Drummonds. We know Lookout is the largest village on Montserrat, so this, the most of the children assessed, and this is for all children, not any particular age group. And the healthy weight is the blue color. So there's some positive, they're looking healthy, the majorities are, but where we have to be of concern is this yellow. These are actually the obese. This one is the overweight, that off-white color, and then the underweight is the red at the bottom. So I'll leave that for a moment, you can look at it again. For me, if I was to be concerned, I would be concerned about the yellow and the off-white, because, as I say, I make very little distinction between obese and overweight, because both of them have clinical implications. All right? When you group them by the year of observation, so the year that we actually measured the children, in the nursery school children, the boys were more likely to be overweight or obese, and this went, there was the years from 2013 to 2018. The other times, there was no significant difference. In primary school, there was no significant difference between boys and girls. In secondary, the girls had a higher prevalence of overweight obesity. One of the things that we used to say the last time I did a similar presentation, quite a few years ago, it was expected because by the time you got to secondary school, the boys were out running up and down and playing football and playing certain cricket and whatever. And the girls started to get dainty and didn't want to mess their hair. And, you know, they would prefer not to be running up and down outside. And when you looked at after-school activities, the boys were much more likely to be involved in physical things. But I want to disabuse you of that notion now because this was the case up to 2018. 2019, 2020, 2021, and 2022. It shifted. The boys are now having a higher prevalence of overweight when compared to their female colleagues. Why? I'm hoping somebody will help me with that one. Right? Because it seems intuitive when we first saw it 8, 10 years ago. So yeah, that's what happens. And you know, we had a few focus group discussions. And literally I had children saying to me, no, I don't want to run up and down outside, it's too hot. And they don't want to play. And I don't know that we can blame this one on COVID. I know everything that happened since 2019, we say, as a result of COVID. I don't know, but this is what is very clear. All right? Now, if you wanted to try to do some risk assessment over time, and I might add, we're not through with the data yet. This was just prepared so that we would have something to show you. There's more work to be done. If we try to run what's called a logistic regression model, which I'm not going to explain. All it is, you're trying to say we're deciding on a baseline. And if we decide that we assign the baseline at 2010, remember I said we have data from 2010 up to 2022. So if you assign 2010 as the baseline, and this is what we decided, being female and being nursery school aged as your baseline in 2010, and then went forward to 2022 to see how each successive year compares to that. You found that children at primary school, as you moved up, by the time you got to 2022, they were almost 2.5 times more likely to be in a weight category that is higher than that baseline year. You with me? Similarly, the secondary school children were 2.6, 2.7 times more likely to be overweight. And girls, as I said before, the pattern continues even when you run a logistic model, that the girls are more likely to be overweight, but that ended at 2018. So it's not just when you look at individual layers, when you do the modeling over time. Being male seemed to have a protective effect. In other words, the boys, were less likely to be overweight when you compare to the baseline, all the way up to 2018. Again, 2019, 20, 21, and 22, that is no longer the case. Remember I said to you that we only had 46 children who we have data for 3 times, right? Could identify the same child 3 times. It was important to note, I think, that 95% of that number, again, I could give you the absolute number, maintained their healthy status throughout. So they were at healthy weight at nursery, and they maintained that. So for me, the take-home message is, it is possible. And if those parents and children can do that, then the rest can also. For those who are assessed as obese at the beginning when they're in nursery, and you do have a couple, not many, at that level, not just overweight, they are very overweight. One child, by the time they got to secondary school, was now being assessed as normal weight. So managed over the years to have some adjustments. And 2 of the children showed improvements in their weight status. They may not have been right back down to healthy weight, but the trend had been in the opposite direction, which is what we encourage. So you congratulate the parents and encourage them. Don't give up. You're clearly making something positive happen. And those who are assessed as overweight in nursery, 4 of those children were able to, you know, as what people say, they slimmed down by the time they got to secondary school. But 3 of the children maintained that overweight and even progressed into what we called the other category, which is obesity. So the take-home message from that it can happen in both directions. So we cannot just throw, you know, let our guards down. We have to be doing the necessary. All right, so I call it time for action. Our previous presenter said we have known certain things for a while. Why aren't we ready? We had known that children have been tending towards unhealthy weight. We know that excess weight is a risk factor for many conditions and diseases. We know, studies after studies have shown that children who are overweight will grow into adults, the majority of them adults who are also overweight and who develop several or multiple disease conditions all at once. And we have also shown that we can stem the tide. We know that healthy children are better learners, and we want our children to do well and to excel. So, the time is now to act, and we know that it has to be an all-stakeholder approach. It's not a Ministry of Health problem, it's not a social services problem, it's not an agriculture problem, it's all of us, because these are our children that we need to collectively intervene on their behalf. I do agree further investigation is needed to certainly understand what's going on with the Montserrat Secondary School aged children, where we're seeing that reversal in trend. What is happening? Is it that the girls are suddenly doing better? And so comparatively, it just makes the boys look more overweight? Or is it that the boys are now changing in general, changing their habits, and so the proportion is rising? It is worth exploring, because then when we get to the bottom of it, we will be able to have targeted interventions. Fair enough? So I wanted to just acknowledge the team who helped to get us to this point, or the entire community nursing staff, medical officers, the dental staff, mental health team, community aides, Ministry of Education, the parents, the headquarters staff who did the data entry, and Abby who assisted with the analysis. And I just wanted to end by saying school health assessments are not new. They've been doing school health assessments, I would like to think, Sister Silcock, for maybe, I don't know, at least almost 50 years. Because, yes, I was going to tell you all, this is my last slide. This is me. The year I went through school health. All right, and this is me in primary school. That's before the growth spurt happened. Just getting ready to go to secondary school. And I have a very vivid memory of the nurses at that time they came to school. I have a vivid memory of them showing up at Fox's Bay, where we were, and taking us through all these different things. And I remember dropping something on my tongue which tasted absolutely terrible, which apparently was a polio vaccine. So thank you for your attention, ladies and gentlemen. I may try to answer any questions.
Yes, so the floor is now open. The microphone is at the back. Dr. Hazel, do not run away. We have just a few minutes before our break. So please, let's get the ball going on discussion and questions.
I just want to compliment you, Dr. Blake, on the presentation on school health. Very interesting. But just a comment, there is additional data that you can access because the nurses check the 8 to 9-year-olds doing obesity screen. So those children in the primary schools, when they reach age 8 to 9, so you have additional data that you can use to see the midpoint between primary school and secondary school. And for that is just weight and height.
Just a quick message for those persons who are joining virtually. We are monitoring the YouTube page. So if you do have a question or comment, you can place it there and we will have it answered. Any others from the audience here?
Okay, so it's a really great presentation, Dr. Blake. One of the things I want to add for your time to action is to look for best practices within the Caribbean that can actually assist the Montserrat population. And one thing I want to encourage teachers, if they're already doing it, kudos to you, but have interesting activities or challenges for your students. So you can have a water challenge, or you can have a fruit day. You encourage children to bring fruits. You make smoothies, so fruits and vegetables, or encourage them to drink water, or so on. So if the teachers are doing it, great job. But if you're not doing it, I want to encourage you to play a role. And if you notice a child may bring some tasty snack or some kind of snack, encourage them not to eat it. Substitute it for something else. When the parents come, you say, you know, okay, we're trying to make certain that we promote nutrition within the schools, so try to avoid giving your children or your child these kind of snacks and try to give them healthy fruits and make use of fruits that are in season, because of course most of our fruits we have are imported fruits, but when we do have fruits in season, make use of it. Instead of having sodas, maybe we can have a ban within schools, ban persons from selling certain sodas and encourage fruit juices and so on. But we can look at best practices within the Caribbean that can assist the Montserrat population.
Agreed.
And yes, I agree with Dr. Watson-Jones, because those were initiatives that were started already, and we just need to continue. And there was another activity that we used to have, the Ministry of Health, Mrs. Benjamin, Sister Foster, with the Easter health camp for a long way in terms of educating the students, getting them involved in physical activity. And I think that is one of the things that we can actually look at starting again, because when you give children the information, they'll be driving that, you know, within the homes. And for the boys, I believe that they still continue to eat the same amount of food because they're growing, but they are taking so much time on the video games that the physical activity is not so important for them
anymore. Okay, thank you. So to Dr. Watson-Jones, I do agree with some of those things we've actually started in the past. We need to do it in a more organized approach, because, and over a longer term period, we did have that little team which had Easter camps, and we did half terms as well, when we would try to pull certain children, not even just the ones who were identified as being overweight, but even those who had family histories, because it's a small society and you know who and who. And you look at a family and you say, listen, this child is part of a grouping that we could do some sort of intervention. And we used to have those activities. I remember distinctly giving a prize, Mrs. Benjamin giving a prize to the Lookout grade 6 class and their teacher 1 year, because she had instituted that whole fruit day and water day and all those activities. It's about us coming back now, regrouping and starting those things again.
Just a quick observation. I remember coming here in 2018 and I was surprised that the children at school didn't get a cooked meal during the day. I know it's a resource issue, but at least if that could be considered, at least you'd know they get one nutritious cooked meal during the day. Because I know at the moment they bring packed lunch to school, or there's a van outside, or people pull up with a car and open the boot. And oftentimes, if you look in there, lunch boxes, I understand there's a lot of sweets, a lot of fast food, a lot of crisp, a lot of stuff in there that the lady referred to. And so, you know, we do free meals for the elderly, we do meals for the prisoners, etc. So I'm wondering why it can't be that we can't organise for freshly cooked meals for the pupils every day. And finally, was there any correlation between the dental checks and weight? Because if there's a lot of cavities and a lot of poor dental health, maybe that will give you a clue as to what they're eating.
Not for this, but it's something we're looking at. But I mean, there is a whole set of dental data that needs to be assessed. So Dr. Dublin is behind and nodding her head at me. We plan to explore certain things further. But at a glance, that does not appear to be an issue, but we haven't finished the analysis. Go back to your original question. There's an interesting dynamic that has to be explored, because I do recall back when we were doing health camps that there were social issues, there was certain perceptions, there were certain parents for whom the thought of a school lunch was absolutely not. It was being associated with certain socioeconomic status and felt like charity, and so my child not going on to school lunch. Even those parents who, based again on our small size, could benefit from not having to make sure I have to give my child a lunch every day, just did not think it was a good idea. So whereas I will not immediately jump and say school lunch, I think what needs to happen is an opportunity for us to sit with all the stakeholders and figure out what is the solution. I had another experience when we were having one of our sessions, and one of the suggestions was, okay, sports day. You're at the park, you're leading up to sports, and you know how it is, everybody gets involved, that perhaps at sports days, and this is a conversation we're having with colleagues then at the Ministry of Education, perhaps we should not be selling certain types of drinks, having a clear definition of what should be sold at the sporting event. And we're told in no uncertain terms by the then president of the Parent Teachers Association of a particular school, oh, no, that is our biggest fundraising day, and these are the things that sell. So you coming to tell me that we should sell X instead of Y is not going to cut it, and we shall go back to selling our Buster and or whatever they were selling. End of story. And so back then, we knew that it is, we didn't give up, but we know that it is a journey that will take time, because this was the president of the PTA. And all they could see was the dollar sign, as opposed to, and I'm saying at a sporting event, you would think, let's combine the two. We had other conversations we had a focus group with parents also, which is why I know that some of them didn't like the idea of this school lunch. And even we were trying to understand, why aren't the children encouraged to run outside and play? And one parent, because when she does that, her clothes get all dirty. So there's a lot of work to be done, which is why I'm going to need you all to help me.
Moment for one absolute last question, comment at the back.
Dr. Blake, very, very interesting presentation. I just had one little comment to make. When we look at the focus group that you said you had, I look at the secondary school, for example, when I go to PTAs, the persons who show up at PTAs are the ones who would make the decisions that you said that they would make, because you don't see, I don't want to say under-marginalized persons, but you don't see certain parents at PTA.
Okay.
And that is something that we have to look at, because when you look at economy and these persons who probably don't have a good job, the things they go to the supermarket to buy are the cheapest things. And these are what the children are having. So we have to take a look at that as well.
Agreed, agreed. And that is why I'm saying our new approach will be multi-stakeholder, and we will certainly, we learned from that. That's not the only one we went to, but that's the one that sticks out. I always remember that conversation because it kind of left me speechless. And, you know, a few things leave me speechless, but that one did. Because I couldn't figure out that, especially the one with the PTA, with the, you know, the dollar sign was more important. And I'm sure if it's hot at the park, you're hot running up and down. If all that's there to drink is this, trust me, they will buy it. But no. We want to have Buster. It was Buster at the time. Is Buster still on the market? I have no idea. All right, thank you very much for your attention.
Okay, so we have reached the end of our first segment. Could we give our three presenters a round of applause? So at this time, we will take a short break, and we will be back here at 10:50 a.m. That's written in stone. So please, audience, return so we can start promptly at 10:50. Some refreshments have been prepared for you on the outside, so feel free to partake in those. My watch tells me it is 10:50 a.m. and I promised you a prompt 10:50 a.m. start. So we are going to continue with our second segment of the day. Welcome back. I see some new faces. Welcome to you. If you are tuning in via Government of Montserrat YouTube page or our Facebook, Ministry of Health and Social Services, we are thanking you for sticking with us. So I think it's fair to say we had a really great first segment of the program, and we now turn our attention to client behaviors and perceptions. And under that theme, we will have 4 presentations, and in order of which they will appear, we have Miss Grethelyn West, Miss Ashley Williams, Dr. Faquita Watson-Jones, and Mrs. Nadine Jubri. Just to tell you a little bit about each of our presenters. First up, Miss West. She is a Senior Health Information Officer within the Medical Records Department at the Glendon Hospital. Her duties, among many, include compiling, organizing, maintaining, and protecting confidential medical records. She also has a keen interest in health research, and you will see her name credited as a contributor to more than one study here today. So every time you see G West, that is the one and only Grethelyn West that we are speaking of. After her, she will be followed by a pre-recorded presentation from Miss Ashley Williams. She's a medical student at the Oakland University. She is expected to graduate in 2024. She visited Montserrat in 2021 under our Visiting Specialist Program with the Caribbean Neurosurgery Foundation. She's on the board of directors of that foundation, and we are attempting to get her live for her question and answer, but if we don't, we will just continue our discussions as we did previously. And she will be followed by Dr. Faquita Watson-Jones. She's a medical officer within the Ministry of Health and Social Services, stationed at the Glendon Hospital. She advocates for health and wellness of youth and women and plays a very active role in our HIV and STI program. And our final presentation in this second segment will be Mrs. Nadine Jubri. She's our newly appointed family nurse practitioner. While newly appointed in that post, she has served for many, many years as a nurse at the Glendon Hospital. And since her appointment, she has taken a very active role in patient education programs. So without further ado, I will now hand you over to Miss West.
Thank you, Penny. Good morning, everyone here and to those abroad. It gives me great pleasure to be here to present this study on visitors presenting at the Casualty Department, Glendon Hospital here in Montserrat, and its dubbed Caring for Visitors at the Casualty Department. This was a joint effort between myself, Dr. Ingrid Buffong, a past casualty medical officer, and Miss Jeanette Lee, a casualty nurse. The data was analyzed by Miss Yvette Holder. The aims of the study were to describe the epidemiological profile of visitors presenting to the casualty department here at Glendon Hospital, and to highlight areas in which the quality of the service can be improved. The format for this presentation is as follows. Introduction, and then we'll go into design, methods, results. We'll have some discussion, and then recommendations and conclusion. So, for introduction, as you said, this study was conducted here in 2023, and Montserrat has approximately 4,500 persons with 1 hospital and 4 government-operated district clinics. Both locals and visitors access services at the Glendon Hospital. For the purpose of this study, the visitor is defined as a person visiting who lives outside of Montserrat. Design. All the casualty visitor records were reviewed, and from these, the following data were extracted and analyzed. That is, client's demographics, time the client was seen, the conditions seen, the health personnel attending the client, and the disposition. And because this is an epidemiological study, it will answer the following questions. Who presented, when they presented, what they presented with, how they were managed, and the outcome. Method. The current review period covers the years 2017 to 2022. The casualty department staff documents all visits, including attendance by visitors. A separate folder is created for each client who seeks medical attention. However, for those visiting the island, their assessment sheet is stored in one folder for the particular year of their visit, and that is known as the visitors folder. Only visitors whose records were stored in the visitors folder with recordings of most of the data items were included in the study. The total number of presentations by visitors may have been underreported due to shifting of staff from the ward to work in casualty, but who may not be privy to the visitors' filing protocol. Data were entered into a database and analyzed using EpiInfo. And permission was sought and approval was granted to conduct the study. This is just an overview. So over the 6-year period, there were 377 visits. This means that there were 62 visits on average per year. As you see from the table, there were increases in visits during the period 2017 to 2019, with most visits occurring in 2019, 112. And then there was a drop between the years 2020 to 2022 because of the pandemic and the travel restrictions that were introduced. Because we know during that time, non-monstrations were not allowed to enter Montserrat during that period. And the quarantine rules also was a deterrent. So this is a graphical display of the visits by year. So we can see that from 2017 to 2019, the steady increase, and then the fall of visits from 2020 to 2022, with 2019 showing the most visits. In terms of visits by month, from this graph, we can see that most visits occurred in March, and this was due to the St. Patrick's festivities. However, there are other local festivals that generated increase and has the potential to have further increase in the future, such as the Calabash Festival during the summer, and in November, the Literary Festival, and in December, the year-end Carnival. So we are going right into the results now. So who presented? 51% or 52% were females, while 48% were males. So slightly more female visits than males. And most of the visits occurred in the 25 to 64 age group. However, there were less visits by clients who were under 5 years and over 85 years. Males presented more than females in the 5 to 14 age group, and this was due to injuries. So we can see So yes, light. In the 5 to 14 age group, so there were 19 males as opposed to 9 females. And males were underrepresented in the 65 years and over age group. So whereas there were 33 females, there were only 23 males. In the over 85 age group, there were only 3 visits, and they were all females. And there's some study that show that women tend to be more healthier than men and maybe stronger to travel than men. Perhaps that's what's happened here. In terms of distribution by country of residence, no documentation was recorded for country of residence for 86% of the visits. This may be due to the fact that the assessment sheet, it asks for place, country of birth, and not country of normal residence. However, some nurses were proactive and asked the visitors where they were traveling from. And of those recorded, 4.2% traveled from the UK, 2% from the USA, including the Virgin Islands, and 1% from Canada. As it relates to the Caribbean, 5.3% traveled from the Caribbean, to include Cuba, with half of these coming from Antigua. Males were So, when did these visitors presented? Most persons presented between 8 a.m. and 4 p.m. And this suggests that they were aware that during this period, a doctor would be on duty and they would get seen by a doctor. And again, there was no documentation of the time of visit for 13.5% of the cases. In terms of presentations by the day of the week, presentations were fairly equal during all days of the week, with just a slight increase on Mondays and Wednesdays. So, what did these visitors come for? Well, we use the ICD-10 codes to analyze the diagnosis, and the largest category was for injuries, 45%. And these included fractures, lacerations, and soft tissue injuries, as well as jellyfish stings and infected insect bites. So not only the typical trauma injuries. 10% were infectious diseases of the respiratory and gastrointestinal tract. And when we're talking about respiratory, we're talking about things like cough and cold, and for infectious diseases, things like gastroenteritis, which includes vomiting and diarrhea. So some of these common conditions could have been dealt with at the district clinic. 3% were related to diabetes, hypertension, and other diseases of the circulatory system. Although this category is small, it may have major significant cost implications, as some of the visitors may need to be medevac overseas for advanced imaging, such as CT scanning. And 4% presented for prescriptions of regular medications. How were they managed? Well, the majority, 52%, were seen by both doctor and nurse. And of the total visits, 18% were seen by doctors only. So what was the outcome of these visits? 92% were treated and discharged, and only 3% were admitted. So of those admitted, they spent on average 3 days on the ward. And some of the conditions that they were admitted for included gastrointestinal bleeding, burns, seizures, hypertensive crisis, and fish poisoning. And there were 2 medevacs overseas. So most of the injuries were due to falls, 29%, and 13% were sports related, with 12% being road traffic accidents. Only 15% of the cases in this study was telephone advice given, suggesting that most clients were properly assessed. We came up with some recommendations. Data from the statistics department indicated that during the 6-year period, there were over 75,000 visitors arriving on island. And this means that when we did the calculation, only 0.49% visited the casualty, which is kind of unlikely. So what we think happened is that some of the visitors' records were filed as residents. So because of this, we are recommending orientation for ward staff who provide coverage in the casualty department. And the Ministry of Health can partner with the tourism department to provide reminders to travelers to bring medications for their period of stay. Because even though we have some of the medications here and some substitutes, there are some that are not stocked locally. And we want them to enjoy their holiday and not to get sick. And families and friends can also play a part in this area. So make sure, though, that you don't say, don't forget to bring your tablet, because they might just think it's the electronic device. So tell them, remember to pack your medication. That's better. And we are recommending, in terms of preparedness, we are recommending that the Ministry of Health officials, that they pay attention to this, the information that's generated from this study, so that they could be in a position to respond to the increase in numbers now that COVID travel restrictions are lifted and things are normalizing. There's already a referral system between the district clinics and the casualty department. So we are recommending that this referral system be formalized, though, so that they can reduce the number of non-emergency visits to the casualty department. The Ministry of Health is in the process of implementing an electronic health information system, and we are recommending that they follow through with this implementation, as it will address most of the weaknesses highlighted in this study. To conclude, or in conclusion, this study is the first of its kind to be undertaken on Montserrat, and it provides a baseline for future studies. Adequate information was available, and so we would like to thank the casualty department staff. And we are suggesting repeating this study in a few years so that we can assess the trends. The following persons contributed to the successful completion of this study, and for that, we would like to say thank you. These are our references. Thanks for listening, and we're now open for questions.
I see the microphone is on the floor, and Nurse Foster is ready to get the ball rolling. So, you take your question.
Good morning, everyone. Ms. West, one of the other recommendations I think that's important, persons are diagnosed overseas, they know the diagnosis or may not know, it would be nice for them to walk with some information from the doctor about the diagnosis or their condition. Because coming into casualty, we may think it's the first time, but they may have some history, and the management would be different because they already know, and they would be able to be referred back to the doctor or the team who is already caring for them, instead of sending them to Antigua and to come back and then to go again. Yeah?
Thank you very much. We'll take that into consideration.
So just one point, as I was listening, you mentioned us partnering with tourism. And I think that's a really, really important point, because I think about the Medivacs and what the cost would have been. Tourism can promote things like travel insurance to make sure people are aware, if you come here, you fall sick, what's going to happen to you. And falls, that one was interesting to me. Where people fall in, is it that they're going on hikes? We have lots of green spaces. Is that where most of the injuries are occurring? Because Then again, tourism would need to play an active role in making sure that the trails are properly labeled, slippery slopes, make sure difficulty level is important, make sure you have water on your trip before you start the trail, etc. So I think it's a really interesting study, and I think we should repeat in a few years, but after we have worked with tourism to improve some of the parameters there. Any other comments before we move on? We have one more.
Good morning again. I just wanted to say a big thank you to Ms. West and the team that did the presentation. Yes, I work in casualty, and we try to ensure that we get most of the information, and especially if I'm on duty, I'll try and ask the person, depending on what they present with, where they are traveling from, especially during the time when we had COVID. And I know Dr. Blake would always remind us that certain things, it's good to have a travel history of the patient. So it's one of the things that we will try to ensure that we try to orientate the other staff that comes into the department to continue. And I want to say kudos to Nurse Lee, because I think she's the one who started the visitors folder. And she's, doing a really good job with that. Yeah.
Thank you very much, Nurse.
Yes, first of all, let me say it's a wonderful presentation. I think something that really needs to take place, and we've heard it over and over again, is the whole question of the referral system. And I'm not sure what that is, but I think it's something that would significantly contribute to persons really utilizing the services that are presented at the district and provide for more emergency type cases at casualty. So I think this is something that really should be looked at, see what can be done to strengthen it and to ensure that it actually happens. So I think that's a good suggestion.
Thank you very much.
Anybody else?
And it's just a suggestion for further research, I think, Greflin, in terms of some kind of exit interview, some kind of patient voice, so that the patients can feedback as to the experience, the waiting time, whether they felt they were dealt with sensitively, etc., that kind of thing. And that would help you to improve the quality of the care you give them, I think. And one final question. You mentioned that you got permission for the study from somebody, but I'm not aware of an ethics committee. So who did you get permission for the study from?
Ministry of Health.
Okay, and how does that work? Is there an ethics committee?
My understanding, all requests need to be sent to the Chief Medical Officer. Until there is an ethics committee set up, anybody required wanting to do research on Montserrat, certainly we're using health data or data collected in our health system, should submit in writing to the CMO, who will then review, and she will usually, depending on the nature of the study, will maybe liaise with people in the area, and then permission is granted.
All right.
Even if you're a student studying abroad and you're doing your dissertation and all of that, you should apply to the CMO. I have one comment too in support of what Penny was saying. Perhaps if you go back to the slide that deals with the main reasons that they were presenting, I think when you relate with the tourism personnel,
the recommendation?
No, not the recommendation. The one that speaks to the main reasons that they presented at casualty, accident and jellyfish and something. It would be useful because, again, in the information they're sharing with the potential visitors and visitors, things like jellyfish things. Some of these people have never heard of a jellyfish until they arrive on island, and they dream of going to the beach and being on the sand, and then you go in the water and all of a sudden, because I've had that experience, and said, we didn't know what this thing was, or they go to rendezvous and bite a mangonel, which has happened, and then end up having severe burns and all of that. So the time is now for us to really do more than talk, to actually have a sit down with the tourist department, tourist board, as the case may be, so that we can improve the chances of a healthy vacation among our visitors.
Correct. Thank you very much, Dr. Blake.
Oh, there we go. Okay, so our next presentation is a pre-recorded presentation. It is coming from Ashley Williams, and just to remind you, she's a medical student who was here with the Caribbean Neurosurgery Foundation. I believe that was in 2021. And she has sent her presentation for us. Unfortunately, she won't be live for question and answer, but again, the floor will be opened after and we can discuss. And you are also invited to keep a note of your questions, give them to us, because there are things that we can have answered and share at a later opportunity. So please enjoy this presentation.
Patient satisfaction and perceptions of access to timely neurosurgical care in the Caribbean low and middle income countries. This work was made possible by the collaboration of my lovely team members, Rachel McClellan, who's a statistician based in the Department of Neurosurgery at Massachusetts General Hospital in Boston, Grethlin West, who serves as the Senior Health Information Officer in the Medical Records Department of Glendon Hospital in St. John's, Montserrat, and our principal investigator, Dr. Myron Roll, a senior medical resident in neurosurgery at Massachusetts General Hospital. I have no disclosures to share. Currently, there are about 3.5 million Caribbean residents who cannot access neurosurgical care. The significance of timely access to medical health care and its impact on a population has been widely discussed. Neurological surgery is a specialized field that deals with various pathological conditions affecting the central and peripheral nervous systems, including traumatic, oncological, and vascular injuries. However, traumatic brain injuries and spine damage resulting from road traffic accidents, assaults, and falls are often underestimated and can lead to significant disability and mortality if not treated appropriately. Studies suggest that in low and middle income countries, traumatic neurosurgical cases account for approximately 74% of the neurosurgical load, compared to about 52% globally. While neurosurgery provides life-changing surgical management in both emergency and elective situations, unfortunately, not everyone has easy access to this specialty. In response, the Caribbean Neurosurgery Foundation was founded to support timely and equitable access to upscaled neurosurgical care for the most vulnerable populations in the Caribbean. In fact, the Caribbean Neurosurgery Foundation responded to Montserrat's lack of neurosurgical access and lack of infrastructure necessary for neurosurgical workup, like in several other low and middle income Caribbean nations. To serve this need, CNF conducted a 2-day outreach trip to Montserrat to provide consultations for patients in April of 2022. The visiting team consisted of 2 supervising surgeons, 2 resident surgeons, 2 nurse practitioners specializing in neurosurgery, and 1 medical student. As the challenges that Montserratians face in seeking neurosurgical care are undefined in literature, we sought to identify these challenges and how they might limit access to timely neurosurgical care. While performing neurosurgical consultations in Montserrat, the CNF team offered patients the opportunity to complete a survey anonymously. This study surveyed patients to evaluate trends of neurosurgical care access in Montserrat, while prospectively accessing current patient satisfaction within the Caribbean Neurosurgery Foundation. Patient satisfaction is a key area of quality and control of healthcare services, as it is also crucial for health system development. Of note, patient satisfaction can serve as a tool for healthcare stakeholders to identify areas of improvement, allowing us to make changes to improve the overall quality of care together. By focusing on patient satisfaction, healthcare systems can improve their overall performance, resulting in better health outcomes and increased patient satisfaction, which ultimately benefits both patients and the systems caring for them. Each participant received a 21-question survey that was distributed by a CNF member. On a 4-point Likert scale, patients were asked to assign their previous experiences and current outlook to agreeable or disagreeable statements of variable strength. Responses were collected and analyzed using summary statistics. Self-reported demographic-wise, we found that all surveyed patients were current residents of Montserrat, and 92% of them identified as Black and non-Hispanic. Overall, many shared strong worries or concerns about a follow-up schedule. If they were able to see a neurosurgeon, they were concerned they may not be able to follow up with one after their appointment. 54% of our participants worried about financial burdens and costs incurred if they sought neurosurgical services. In this case, services provided by CNF were pro bono and completely covered for patients. However, this is normally not the case. Lastly, the majority of patients were very satisfied with their care that was provided by the CNF visiting team, and 76% of participants said they would definitely return to CNF to access care again. Future directions would include exploring interventions and infrastructural initiatives that can contribute to equitable neurosurgical access for all. Of note in our summary, we found that 85% of participants said that a full-time neurosurgeon in Montserrat would be beneficial. Here we see how listening to patient cares and concerns and elements that drive patient satisfaction can become cornerstone for how we collaborate and develop solutions together. Thank you so much for your time. If you have any questions at all, please feel free to email me at ashleywilliams@oakland.edu. Also provided is my Twitter handle at @awilliamsmed for any other questions or concerns. Thank you again for your time. I really appreciate the collective interest in this work.
So any discussion points from the audience that anyone would like to raise? Nobody? One thing that I remember from their visit is one of our residents who's been very vocal about the positive care that she received and the timeliness of their visit. There was one of our residents who was having a neurosurgical issue, and if it were not for this team visiting, she would not be with us today. And I don't have her permission to say her name, but I won't, so I won't. But she's been very vocal speaking about it, and I think it really speaks to access being really, really absolutely important. And I also think it speaks wonderful things for the Ministry of Health in terms of finding avenues to make care available. And this was the opportunity that Montserrat has that many other Caribbean islands don't have. They don't have a visiting specialist program, and patients lose their lives every day because they don't have access to this critical care. So I think this was, the fact that they visited was absolutely great, and I hope that we can have future visits as we go on, and it can become maybe a routine part of our healthcare. I also think it speaks a lot about needing health insurance. I'm sure if they conducted this study now, just a year or two later, that number of persons worried about the financial burden of treatment would be greater. So I think it also represents an opportunity for us to push for health insurance as something that every person should have. So there are no comments, no discussion points anyone wants to have addressed before we move on to our next presenter. Yes, I see one at the back.
Thanks, Penny. Again, CMO, for those listening online. Just to comment about neurosurgery. So this team, they presented at a regional conference, and then they reached out to individual countries to see, who would be interested in having an outreach program. And of course, I was like, yes, please. So it was very interesting in terms of the justification for it. Had to use the numbers, justification locally, that is. We had to look at the number of patients experiencing neurosurgical issues. But what was good is that they also said that they were willing to see persons with neurological issues. So not necessarily with a structural problem with the neurological system, but also medical issues. So by doing that, we were able to increase the numbers. And so, persons who suffered a stroke, for example, were able to be assessed by this team, and they could offer recommendations. So just to say that even next door in Antigua, they don't have a neurosurgeon. So when you think about things that are acutely life-threatening, like head injury, for example, so you fall, you may have a fracture to your skull, and you may have bleeding on the brain, and so on. Antigua is not necessarily the next best step for our patients. So that is where we would look to the French islands for assistance. And I mean, there are challenges with medevacing a patient, for lack of a better term, the medical transfer that occurs. So it is an acute problem. Again, something that we are looking at. I know that Antigua is exploring the possibility of getting a neurosurgeon full-time. For that, they are exploring which countries that are close by to them that would benefit from that service. And if you can imagine the cost to maintain a full-time neurosurgeon, because this is a person who has to study for at least 8 years to attain that qualification, you can only imagine what their salary is like. And of course, you'd want them to have enough work. Not that we're hoping that people will have issues, but in order for them to stay current and be good at what they do, medicine is literally a practice, so you have to keep your skills up. So it is a problem not just for Montserrat, but regionally, because the nearest neurosurgeon, if you're excluding the French islands now, you're talking about Barbados. And then next door to that, I think maybe Grenada has one. And we've also used Trinidad and Tobago for neurosurgery consultations, and interventions. The important thing to note as well, when you have a person with a neurological problem, putting them on a plane and increasing the altitude is not necessarily the best thing for them in terms of managing their issues. So we won't get into the technical bit because we have members of the public who are not medical professionals, but for the medical professionals in the room, you understand that there is a pressure system within the skull, and that is why having a bleed on the brain is such a significant issue, because you have compression, you can cut off the brainstem, and then it starts affecting other systems in the body, your breathing, the way how the heart pumps, etc. So it's a time-sensitive issue, but also, as was mentioned in Dr. Buffong's presentation earlier today, not everyone can be medevaced. And then you have the added issue of Montserrat and our airport. So we're limited by our runway length, so we don't have special air ambulances that can land. We had one before, but now with the change in regulations for landing in Montserrat, that air ambulance is no longer available. And also, you're talking about an airport that's only open between 6 a.m. and 6 p.m. So it means that we really need to look at being able to manage our patients locally, which is why the high dependency unit is important, but also telemedicine, having, and one of the things that they were exploring was how can you train your local surgeons to do basic interventions? So something called a burr hole. I don't know how many persons are familiar with that. You literally drill a hole into the skull, remove the blood from the brain. I mean, that is an intervention that would have been developed many, many years ago. And of course, medicine has advanced since then. But for resource-limited locations like Montserrat, sometimes we still have to rely on the old and faithful methods of treating these things. So it's how can you train persons to do that? How do you make sure that you have the equipment on island to do that, and also an operating theater that is suited for that type of procedure? So all of these things are what we're taking into consideration with the construction of the new hospital, to make sure that our operating theaters can manage procedures like that, because you're talking about infections. You don't want to worsen the patient by then introducing an infection on the brain. Right, so we're taking all of that into consideration, and we are, yes, hoping that this team can come back. It's about availability of the team and also funding. Unfortunately, it's not something that we can fund from our visiting specialist program. So the more outreach programs that we can benefit from like this, we try to raise our hand and say, yes, please. So just to give you just a little information about what we're doing in terms of neurosurgery and also a little bit of neurology here in Montserrat.
Yes, thank you, CMO. We have time for maybe just one more comment, and if anybody has something that's really on your heart that you want to say. If not, I'm going to move swiftly along. I see no takers. So I will now invite Dr. Faquita Watson-Jones to give us her presentation.
Menstruation, a normal vaginal bleeding that occurs monthly on average, is now an issue, a public health issue due to unmet menstrual needs. That is basically caused by key factors, mainly being poverty, gender inequality, and of course, cultural taboos. Therefore, menstruation matters. Let us bring an end to these bloody limits. Good morning, ladies and gentlemen. I am Dr. Faquita Watson-Jones. Yeah, sorry about that. It is my aim, through my policy brief that I would have completed for my Master's in Public Health program last year, to bring an end or basically reduce school absenteeism among schoolgirls in Uganda. As such, my policy brief addressed schoolgirls' menstrual hygiene management interventions on school absenteeism in Uganda, a review of the evidence base. In order to execute the policy brief dissertation, basically, I would have utilized the University of Edinburgh Masters of Public Health coursework, including the SURE guides for preparing and using evidence-based policy brief, and the support tools for evidence-informed health policy making. It is with this policy brief that I do hope that I will be able to clarify the problem that we have in Uganda by basically identifying factors influencing the management of menses within the school system in Uganda and investigating strategies applicable for policy intervention by health and education leaders to successfully resolve the issue. Now, let me paint you a better picture of the issue within Uganda in the school system. Globally, there are 1.8 billion menstruators. That includes women, girls, transgender men, and non-binary persons. And in order for them to menstruate every month, adequate menstrual hygiene management is an important requirement. But what is adequate menstrual hygiene management? According to the United Nations, it's basically having access to clean menstrual management materials to absorb or collect blood, being able to dispose of your used materials effectively, having a place to be able to change your materials during your menstrual period, and having access to soap and water for washing your body and hands. However, that is not the case in Uganda. As such, these young girls, these schoolgirls, basically face several challenges. And it's not just basically the lack of the materials or the facilities, but these challenges go beyond to physiological challenges, social and economic challenges, and of course, the issue of the lack of system acknowledgement. Can you believe, and you may say, but why? Why is there still a cultural taboo in this day and age? There is still a cultural taboo, especially when there's a culture of silence. Imagine not being able to speak about when you are menstruating. Imagine men not being able to disclose of it, and they have no knowledge of it. Also, imagine not being able to have access to these materials when there's a need to be able to change. As a result of the culture of silence and also the fact that there is a lack of materials and there is lack of information sharing, especially among parents, teachers, and community members, you find that these schoolgirls now have unhygienic, unhealthy menstrual practices, which is basically giving, which promotes also negative attitude among others, leading to shaming, bullying, and even gender-based violence for the school girls. Now, if you think the school system will actually assist with the menstrual hygiene management, it actually is not, especially when you consider the school curriculum. Yes, biology is taught within the school curriculum. Yes, biology is taught within the school curriculum, but they are basically providing these children with information, They are basically providing these children with information that is talking about the male and female parts, but not giving the children practical life skills that they need. And that is important, considering, if you remember, ladies, when you first had your period, you may or may not have felt a lot of pain. And imagine how that pain made you feel. So imagine these schoolgirls experiencing pain, excruciating pain, and they do not know what to do because they don't have the practical life skills that is needed, basically saying, okay, you can use painkillers. But even so that the school system is not providing that to them, there's also the whole fact of the cultural taboo where they feel that if they use painkillers, it's going to make them infertile. And because the school is not playing a good role in trying to reduce school absenteeism, you now find that, of course, it's going to have a great impact on the education. According to the World Bank, if a girl misses at least 4 days of her school, every 4 weeks during her period, she will basically miss about 10 to 20% of her school days. In Uganda, school absenteeism is about 28% compared to when she doesn't have her period, which is 7%, and this is basically in the secondary school. Within the primary school now, school absenteeism is translated into a loss of 8 to 24 school days per year, in which there are about 220 learning days. That is equivalent, if you do the 24 days, that's basically equivalent to 11% she's basically losing. Now, there's a big economic challenge when it comes with the provision of these menstrual management materials. The average family in Uganda cannot always afford a pack of 7 to 10 disposable sanitary napkins, since it costs 1/10 of a family's income. Additionally, they may have access to these menstrual products in school, but it is inconsistent, and because of the inconsistency, of course, these girls are now faced with shame, bullyism, and so many other factors. And if they're in school and they have their menstrual period and they do not have access to the right menstrual products, they will then use alternative sanitary products. And that goes to include a piece of cloth, underwear, mud, newspaper, leaves, and so many other things that they are using. And if you think it's just basically the lack of these menstrual management materials, imagine not being able to afford a simple thing as underwear, which we are all privileged to be wearing. So as a result of not being able to afford a simple underwear, they now find an alternative, which is basically a piece of cloth wrapped around their waist that is not only used as an underwear, but also to be used as a menstrual hygiene management material. Of course, I don't need to tell you this will increase the risk of having infections. And even if, because we may know that basically there is disposable pads, but there are also reusable pads. I don't know how many of you have used a reusable pad or have access to it, but it goes to the olden days when our grandparents used to use a piece of cloth tied onto the underwear with a safety pin. It has the basic concept of it. But imagine if you have access to reusable pads where you have to wash it with soap and water and hang it out to dry. Now, there's a whole myth that if a young girl leave her reusable pad on the line to dry, it may go in the hands of the wrong person, which being the witch doctor. And if it's in the hand of the witch doctor, they can become infertile. So what happens now? We find that these young girls do not leave their reusable pads to dry outside, so they were damp, and of course increases your risk of infections. In terms of the poor wash services that we have, the poor wash services in school does not just mean having access to clean water and soap to wash your hand, but imagine going to a facility where you don't have no proper doors, no bolts to be closed while changing your sanitary products. That means you are then faced with a high risk of being sexually abused, and that happens most times in the case in Uganda by boys and male teachers. Then there's poor lighting system with within the washroom. Additionally, they do not have access to sanitary bins or so to dispose of their products. So what happens, they throw it in the latrines, which has a very great depth, and also by throwing it in there, they know for sure no witch doctor or anyone who have malicious intent will collect those. So the poor wash includes all of those components. Now, education experts believe that, hey, I can solve this problem by pouring large amounts of money and buying these children's sanitary products. But that doesn't solve the issue, because menstrual hygiene management is not just about pouring your money and buying products for these girls, but as I said before, it's a component, it's an entire cake. You can't just give me a slice of cake and think I'm going to be satisfied. You have to make certain that I have everything. Safe disposal areas, I have to have my education, I have to be educated on all these things. So even though these large companies would have poured the money, still they didn't solve the problems. And so the unmet menstrual needs in Africa is still an under-examined area that, of course, shows very striking impact. On the contrary, so other experts believe that, hey, I can do pads and I can educate these girls, but yet it goes beyond that. In 2012, Uganda realized that menstrual hygiene management is a big issue. It's a public health issue. So in 2015 November, the incumbent President Yoweri believed that during his presidential campaign, he is going to promise that if he's re-elected, he's going to provide free sanitary pads along with free stationery to students who are attending the primary education. But as every person who wants to be elected as president, they make promises. So he didn't keep his promise. And Stella, who's an advocate in Uganda, knew that he wouldn't have kept his promise. And so she was actually arrested in 2017 because she would have spoken up. Advocates usually like to speak up and let persons know how they feel. So she spoke up at the president and his wife, who at that time was the Minister of Education. So as a direct challenge to his failed promise, what she did was had a public launch of Pads for Girls UG. And that is basically where they would have collected pads, distributed to schoolgirls in Uganda, and boys and girls would have also benefited in terms of education. Now that you have a better picture, and my throat is dry, so excuse me. Now, how do I intend to actually have evidence-based policies developed in Uganda? Because obviously I'm not the first person who would have tried to say, I want to reduce school absenteeism. I wish I was, but no, there were other people who would have tried that. So what you actually have to do is to have an evidence-based literature. So in doing so, I would have basically used the PICO model search, and I would have created search strategies using non-specific searches. And these non-specific searches were used to basically test and modify my search strategy. In doing so, I would have created a list of inclusion criteria and exclusion criteria. So my inclusion criteria was basically having a study focusing on menstruating schoolgirls between the ages of 10 to 19 years, having an intervention-focused publication in low, middle income and high income countries, having a study between 2012 and 2022, because that's when Uganda realized it's a public health issue, and having studies focusing on reducing school absenteeism by improving the school acknowledgement and resources, having publications in English and studies focusing on the historic practice of cultural taboos. My exclusion criteria, of course, studies focusing on young adults and women more than age 19, studies that have not focused on a high level of school absenteeism, and as a result of lack of system acknowledgement and resources due to inadequate menstrual hygiene management, studies not focused on a historic practice of cultural taboos, and intervention-focused publication in low to middle income countries only. So basically, I would have generated about 500 publications. After the duplicated publications were removed, there were 200 articles. That was on an initial screen by just looking at the title and abstract. And then by doing a full screen of those 200 articles by using inclusion and exclusion criteria also, I ended up with 5 articles. So from the 5 articles, they would have basically showed that there are several interventions that can actually be applicable to the setting of Uganda. However, in choosing these in choosing the appropriate policy options, I would have consulted with my key stakeholders, my very good friend Lisa Hertz, who is an entrepreneur and an innovator from Toronto, Canada. She's also the founder and the principal of Global Health Innovations and the founder of Be Free Menstrual Cups. Through Lisa, I would have met my Uganda friend, Samara, who is actually, she would have conducted a pilot intervention study in Uganda called Meniscus 2. And she's currently a training coordinator with an NGO called Womena in Uganda. So basically, through my consultation and telling them, okay, these are my different interventions. Which one do you think will work in the setting of Uganda, since you would have done work there and you live there and you know what is happening to your people in Uganda? My 3 policy options that I've decided to choose would be the production of the MESI pads, pain management with pharmaceutical and non-pharmaceutical methods, and the provision of education on menstruation and menstrual hygiene management. These interventions, all interventions when it comes to menstrual hygiene management, can be grouped into 2 categories, hardware or software interventions. Of course, hardware interventions will speak of materials, software intervention will speak about knowledge. Sorry. So in looking at the MESI pads, I want you all to know, by the way, they are actually a company that produce reusable sanitary napkins. So there's actually free pads that are distributed as a menstrual kit that consists of 4 reusable napkins in a storage bag with a 12-month life cycle, 8 hours of usage, 2 hours of drying after washing. And one kit will cost 750 euros, which is 756 US. That is the cost of one kit. Yes, very, very expensive. So because it's very expensive and it has it's not so effective when compared to other pads, what I've decided is that, hey, these girls can actually produce their own reusable pads. In Kenya, they actually produce the MESI pads. So why not have this intervention in Uganda? And after all, there's benefits because the basic material that is needed, you can actually get it locally available in Uganda, and it's relatively cheap. However, what is the downfall of it is that I do not know if these students do not actually have sewing as a skill. So now what will have to be done is that we have to find a way in the school curriculum to include sewing. And there's a lack of access to soap and water to wash the MESI pads, especially considering which part of Uganda you live in, if it's the rural or the urban areas. And of course, we have to consider that in Uganda, there's a deep-rooted culture of the taboo. So we have to consider that will be a possible harm when it comes to the production of it. However, in evaluating the equity impact, the local materials may not be readily available to the entire study population in Uganda, especially the rural part. And by saying it's relatively cheap, that is subjective. The cost and resource consequence is that it's going to reduce school absenteeism at least by 6 days per term, and that has been shown in other countries like Kenya, that it has greatly reduced school absenteeism. And of course, imagine you having a skill to be able to produce something that you are in dire need of. You're going to empower so many schoolgirls. In analyzing another hardware policy, I want to talk about pain management with pharmaceutical and non-pharmaceutical methods. as we women who menstruate, we know that having painful menstruation is not something easy because there's so many symptoms that we can have. But if we have this as a policy implemented, we know for sure if we produce these painkillers to these children, they're going to have quicker relief, at least within 2 days, maximum of their menstrual pain and associated symptoms. We know that, okay, if we do it in a way that we can share our vouchers to these school children, so we can give vouchers to exchange up to 6 paracetamol tablets or Panadol, same thing, per month from the school nurse or the school senior teacher or the local pharmacy. But what is a possible harm? If now you're menstruating on the weekend, pharmacy closed, there's no school nurse there, you're going to have your pain, so you will have to suffer with your pain, so that's a possible harm. Now, in looking at the software policy, I want to have the implementation of having education on menstruation and menstrual hygiene management, because having that baseline knowledge, it's very key in making changes. But of course, we cannot just have the simple, hey, talk to the children about what is menstruation. So let's make education creative. Why not incorporate drama? Of course, anything, I don't know about you, but if I see a little bit of drama, something, I will definitely remember information. So if you make your education interesting, you're going to reinforce the puberty knowledge to these children. You're going to reduce the stigma engagement of having boys having a negative impact on our girls. You're going to reduce the psychological outcomes, especially for girls. What is the cause? Well, resource constraints should be considered when teachers and parents may have difficulty adjusting the schedule, because we just don't want to also have it just for the school girls, but let's incorporate everyone, parents, teachers. So it might be difficult for them to adjust their schedule to be part of the training. Like every good policy, you must have an implementation strategy. So I won't go through all my barriers, but we can have a good policy and it poorly implemented, or we could have a poor policy and it's poorly implemented. So just quickly, I am just going to look at the recipient of care at the level, because you have to, every policy, you must look at different levels that you can actually see what barriers you have. So one of the things I have to speak about is the cultural beliefs. So one of the things I want to do in order to try to avoid that is by collaborating with key stakeholders. So I want to have a multi-sector, multi-level strategy towards it. So to collaborate with various ministries, key stakeholders, so that they can be part of it. I want to have sensitization sessions at least quarterly, and of course do an M&E to monitor and evaluate how it's going, especially have sensitization sessions too with organizations that will already be providing such sessions, and see how it's going. And of course, if there are any health clubs or any form of clubs within schools, we should also utilize that. And how does that pertain to the context in the Caribbean? Well, we all know cultural taboos exist within the Caribbean too. And if you don't know, there's actually menstrual hygiene management issues within the Caribbean. Yes, there's a lack of data, but you still have it. And so as close as Antigua, Tanya Ambrose, who's the CEO of a company that deals with education of girls and women, she normally distributes pads and provide education to young girls in our home country, Antigua, and also in the USA. So in the context of Caribbean, I want to encourage us all, whoever's live or so from different Caribbean countries, it is time for us to do studies. If you've done studies, please publish it. In terms of the Montserrat, I am hoping that I could possibly have a study done looking at menstrual hygiene management in Montserrat. Thank you very much.
Thank you, Dr. Watson-Jones. So we will jump straight into Q&A and discussion. I for sure have a lot of thoughts about what was presented, and I'm sure you do too, so I will allow you to go first. The microphone is available.
That's so insightful and very educative. But I'm just confused. You made mention of transgender males. What's the correlation? I want to understand. Are they menstruating? What does that mean? Is the concept
It's a
or something?
woman that just decided that she's going to transition into a man. So it's transgender man. So yes, they're still menstruating.
We just have to remember that the transgender men, unless they've had surgery, they still have a uterus.
Good morning, Doc. Good morning, everyone. I am curious about the reusable sanitary napkins. How does it work?
Okay, so it's basically, I have a picture of it on one of the slides. I don't know if you can see it clearly, but the flat part has a clip. So you clip it onto your underwear. Then the inner part is where you have the lining. So it usually comes with at least 4 lining, and it's usually as thick as your normal pad. So you just insert it there, and it's usually colorful. So they make it colorful to make period fun. But it's basically, yes, and you, in terms of, but nevertheless, it can be folded and it can be in your hands very small, like if it's a very small purse. But it's just basically you clip it at the back of your underwear, you put your liner, the padding there, which collect your blood, you take that out, you wash it with soap and water, you hang it out. So it usually comes with the backing, and then the liner, they will have it like a package of 4 inside. They will have a little salt soap or blue soap, and they have a calendar so you can actually like mark off how your period coming in, so when they pack it, yes.
Okay. I have a question. Just like how Nurse Brown was interested in the reusable pads, did we consider the period underwear that is now like a new trend taking over in the US? There is I can't remember the name of the company. Is it Ruby Love or something like that? There are several companies now that are producing these underwear, even swimsuits, that are very absorbent in that area, and they claim that they can take, X amount volume in terms of the flow. Very tempted to try it myself because this whole pad thing, yeah. But I just wondered if that was considered. And initially, when I looked at the cost, so when they just came out, they were expensive. But slowly, you're seeing the price starting to come down. And I'm wondering if that would be a more cost-effective method for this population in terms of donating. But I understand that there are other cultural issues. So, I mean, if they're having issues with hanging out the things to dry, then that would be an issue as well. Mm-hmm. And, I must say I was very traumatized by your presentation. But it's very good to raise awareness about issues in other countries. And then it would be really interesting, as you say, to look at Montserrat and see if we are having issues in that area. I hesitate to say period poverty, but you just never know, right? Until we really look for it. If you're not looking for it, you're not going to find it. So I thank you very much for your presentation.
I enjoyed your presentation. You were very passionate, and I did enjoy it. I'm not sure if anybody is aware or has the answer to my question, but pads are really expensive, as we know, as women, and over the years, they've become more expensive. So I'm curious that if someone knows, is producing pads a costly thing, or is it just the fact that they know that we need it and it's a money-making thing? Because, I'm curious to know if anyone has that answer, because as the years go by, you know, your cycle changes. Some of our cycles could get shorter, some of our cycles are long. You could be wearing pads for a whole week and changing consistently. And having to buy pads for like $30, somebody mentioned $50 and stuff like that. So it is a costly thing, even for those of us who are gainfully employed. You have the answer, Penny?
So just one thing, sorry, I'll send it back. Based on what you said, she mentioned the cost, and we can see that it's big business. It's business, and there's a lot of research around something called pink tax, which is where female products cost a lot of money because we need them, so we have to pay for them. And just to share an initiative around sanitary napkins that happened here in Montserrat, we had WOM, Women of Montserrat Bonding, the representative is right behind there. And they were able to distribute 6 months' supply of sanitary napkins to all the girls of the Montserrat Secondary School. And they got us such a large supply that we've been able to continue to distribute. So during our school health program, some of the young ladies were able to get sanitary napkins there as well. And I think it boils down to big business. And just another comment, I heard a lot of snickering because it sounds funny when she started to talk about the witch doctor doing things with your blood. That is a cultural belief in the Caribbean.
Yes.
And I've experienced it on two locations, two experiences in two different locations where someone spoke about it to me. Two people from completely different backgrounds, different countries, and they both practice basically stripping their pads to bits to then flush away because they do not want anybody to pick it up and do anything with the blood. So while we were laughing and it sounded funny, you know, it is something that is real, and it is found right here in Montserrat and in other parts of the Caribbean.
And may I also add, it was actually a culture shock for me when I came to Montserrat and realized there were no sanitary bins per se. You know the sanitary bins I'm speaking of? So when I went to the hospital washing and using, I was like, where is the sanitary bin? And I'm like, that's where I have to put my pad? And I'm like, all right, I'm going to dispose of my pad. So I have a colleague. When she came in, I said, girl, how you not finding no sanitary bin? She said, guys, wrap it up, put it in my bag till when I reach home, I throw it away. I'm like, okay, just checking, because I know persons will have this mentality, okay, you put your pad there, you don't know what's going to happen. I'm not saying that, okay, I'm thinking about that, but it was just a culture shock when I saw no sanitary bins. And I was wondering, because I know when you have these sanitary bins, it's a particular way you dispose of those pads. So now I'm wondering, how they dispose of those things? Because it's paper, everything wrapped up there. How you disposing of it? And of course, the smell from your period and all that. If you don't change it regularly, you're going to have that smell. So that was a culture shock for me.
Dr. Watson, I was very intrigued by your dissertation process, and it's highly commendable with the amount of work that you would have conducted over a period of time. And I just wondered, based on the cost implications, if a further consideration could be for period cups, which is a new advancement also, and given that the young ladies in Uganda are not able to afford proper materials.
So actually, my friend Lisa, who I would have consulted with, that has the Be-Free menstrual cups, she actually shared that out in Uganda. So because she does work within the country, but then there's the idea of the whole taboo of using your menstrual cups, how you're going to clean your cups and all of that. So at the end of the day, the main thing that's affecting the whole menstrual period thing is the whole cultural taboo that we have to address. So that's why having continuous education for everyone, let them know, okay, this is how we have to dispose. There's nothing that's going to happen when you dispose. No witch doctor, nothing. But they do have the menstrual cups in Uganda, but not everyone approve of it.
So 2 points. The first, well, maybe three. The first one, you mentioned that the Mezi pads, they cost about $750 US.
No, that was the Afri pads. So the Mezi pads is what I want the girls. So the Afri pads is what costs the 750 euros.
Are there cheaper options, or is this the general price range for these kits?
That's actually the cost when I checked in certain literature. So there's no cheaper price rate for it. So that's and actually, yes, actually there's this international organization called Days for Girls. It's in Guyana and other countries, and it's actually a bit pricey too when you have to purchase it. Speaking from Guyana, because I would have my organization that I'm part of in Guyana, where we do menstrual hygiene management, we would have purchased a certain amount, and the cost we pay was very pricey. So because you have to consider the materials that you have to use to make these things, and it may not be available in your country. So making that in Guyana, you have to source it from America. You have to consider shipping and all these things. So if we can make the Mezi pads, which is done in Kenya, the materials in Uganda is actually available, so it makes it easy. They don't have to spend no particular money. We just have to teach the girls how to sew and make the pads while empowering them to make something for themselves.
Okay, and thank you for that one. And in terms of, I think Dr. Greenaway referred a bit to the situation here in Montserrat in terms of the period poverty not being maybe such a big issue. But for me personally, I found it's a bit difficult sometimes to find the brands that you prefer.
Yes.
So like I've literally gone to every supermarket looking for a particular product that I could work with, and I couldn't find it. And for me, that was a lot stressful. So much so that I resorted, the last time I went home, I bought them in bulk and brought back with me. So while it may not be quite as severe as in Uganda, it is a challenge here as well.
Yes. I must say it's basically a challenge in all Caribbean countries, but the only thing is we don't actually have the studies to support it. But if you interact with persons from different Caribbean countries, you realize they face different challenges as it surrounds that.
Okay, thank you. So we've reached our final presenter in this our morning session. And just to remind you, the theme for the morning is client behaviors. For this session in particular is client behaviors and perceptions. You heard from Brethlin West, you heard from Miss Ashley Williams, you just heard from Dr. Faquita Watson-Jones, and now I will invite our family nurse practitioner, Nadine Jubri, to take you through her presentation.
Good day, everybody. As Penny said, I am nurse practitioner Jubri, and as part of my dissertation for my master's degree with University of the West Indies, I chose to do my study on communication on herbal medicine because herbal medicine is on the rise. And no matter how you want to put it, patients are using it, and we have to come to grips with it doing it, and we have to, as medical professionals, upgrade ourselves to deal with whatever, because there are very many consequences with using and not using herbal medication. So it was start communication between patients and the healthcare providers regarding herbal medication use, and that was just for the primary healthcare system, so the 4 primary healthcare centers. So the objective was to determine the prevalence of patient disclosure of herbal medicine within the primary healthcare system, to identify the level of satisfaction regarding the communication of herbal medication use to their healthcare providers, and to identify factors that influence the quality of communication between patients and the healthcare providers. So herbal medicine, as I said before, is on the rise, and it's a collection of medical and herbal activities and products not commonly considered part of modern medicine. Herbal medicine has been utilized all over the world for decades and is increasing. Its use is becoming more common among patients within the primary healthcare system. Herbal medicine has significantly improved its ability to improve health and disease outcomes. So an anecdotal report from Montserrat revealed that patients have made herbal medicine a common practice since they perceive it as more natural, it's chemical free, it's readily available, and we'll see why, and it holistically it's effective in their view. They also believe that conventional medicine is not as effective, and they must consume too much in order to get better, and sometimes they still don't even get better. So why use so much and I'm still not getting any better? When I go to doctor, I'm using one this month, and 3 months I go after. Doctor say, we have to add something else, and it adds and it adds and it adds. Patients on occasions can provide evidence of
We'll be back on. To everyone joining us virtually, just to let you know that we've experienced a power outage and we will resume our coverage as soon as that is sorted. Thank you for staying with us so far. So we are once again live after an unexpected break, but this is Montserrat, and that's the nature of things, where sometimes the power surprises us and it goes. So we are going to resume with Nurse Jubri, and I think it might be a good idea for you to restart from the beginning, and we'll go through her presentation.
Okay, so good afternoon again, everybody. And as I said initially, that my research paper for my master's degree was done in accordance with the University of the West Indies, and it was entitled Communication Between Patients and the Healthcare Providers within the 4 primary healthcare settings on Montserrat. So the objectives were to determine the prevalence of patient disclosure of herbal medication use within the primary healthcare setting, to identify the level of satisfaction regarding communication of herbal medicine use among patients and their healthcare providers, and to identify the factors influencing the quality of communication between patients and their healthcare providers. So herbal medicine is a collection of medical and healthcare activities and products not commonly considered part of modern medicine. Herbal medicine has been utilized over the world for decades and is increasing. Its use is becoming more common among patients within the primary healthcare system. And herbal medicine has significantly proven its ability to improve health or disease outcomes, and patients will tell you that every day when you see them. So anecdotal report from Montserrat indicates that patients have and is using herbal medicine, and it's a common practice. They perceive that it's natural, it's chemical-free, it's readily available, and holistically effective. They also believe that conventional medicine is not as effective, and they must consume too much just to treat one condition. And as I was saying before, you come to the doctor and they will say, but doctor, you're giving me this now. And 3 months down the line, they come again and you have to add something else, and they want to know why. And they will tell you straight up, I'm going to use my bush. But how effective that really is. Patients on occasions can provide evidence of how the use of herbal medicine aids in their control of their chronic illnesses. And as I said before, they continue to use it, and it is prevalent in Montserrat. So effective communication. Effective communication among patients and the healthcare providers is essential when considering herbal medicine use. And this is due to the pharmacodynamics and the pharmacokinetics of implications of using it with conventional medication. The disclosure can aid with treatment information, thus avoiding or reducing any adverse effects and drug interactions possible when you combine herbal medication with conventional medication. And this is so true because there most times, depending on what the herb is, it can interact with the medications that you use. Some of the possible signs are liver cirrhosis is one of those things that can really that can happen. Right? So the methodology, descriptive cross-sectional study designed using a 30-minute long interview administered questionnaire comprising of 18 questions aimed at determining the level of communication between patients and the healthcare providers regarding their herbal medicine use. This study's design was cost-effective since it captured a population at a specific period in time and did not require any follow-up. It also examined the entire population and helped assess disease prevalence, communication level, their attitudes, their attributes, and knowledge. So the population and setting. So the population of this study were patients who were, or persons who were 18 years or older, who attended the chronic disease clinics within the 4 primary healthcare centers in Montserrat. And this happened between 8 and 4, which is the clinic hours, and a 1-month period was used between June 1st and 31st, 2022. Also, the primary healthcare center's annual report for 2020, which registered 3,086 visits with an average of 257 patients. Patient visit per month was also used. So recruitment and participants. Participants were recruited on the designator's day, the day of the chronic illness clinic. That's when they would come in, and the researcher was the one who would come to me. I would talk to them and tell them what it was about. So upon arrival at the healthcare center, the prospective participants were approached. They were given details of what the study was all about, and they were invited to participate. Once they agreed to participate, they were taken to a room which was designated, and the participants were asked to fill out a consent form first, and then the questionnaire was administered. And I decided to do it as an interview administrative questionnaire because I didn't want to lose some of the questions, because even during the interview administered questionnaire, they was like, what do you mean by that? Or what is that? So I didn't want people to not understand, and that would have that would affect the data that I would have received. So sample size and the sample and the sample size. A non-probability consecutive sampling over the 30-day period was used to select the participants who participated in the study. Using a 19% estimated prevalence of patients who did not disclose their HOBA medication use to the medical practitioners, a sample of 236 was needed to detect a difference of 5% with a 95% confidence. So this 19% estimated prevalence was from a research that was done in Jamaica regarding the same thing, and that was used to calculate my population that I would need to conduct my study. So this calculation from an average clinic population per month of 257, so that's what I needed to conduct my study. However, during the study period, clinic attendance was lower than anticipated. So at the end of the recruitment period, 158 participants had been recruited into the study. Although the sample size was reduced, it still permitted the detection of a 6% change in the prevalence with 95% confidence. So because of COVID, it was COVID period, and patients weren't coming out as they should to the clinics, it interfered with my study population, which was originally supposed to be 257. So the results. So the demographic characteristic of the study population. So most of the persons who participated were Montserratians, so 75%. 20% were from Caribbean countries, and 4.4 was from other parts of the world. Females, as in everything else, was a dominant gender, and participants ranged from 22 to 97 years, with a median average of 66.5 years and a mean of 65.4. The majority of clients were single and only obtained primary education. Health status and service utilization. More than half of the respondents attended the health center for their regular scheduled visits. And I must commend the primary healthcare system, because patients come and they keep their schedule and they do whatever they were supposed to do, which was really good. And two-thirds, 66.5% of the clients consider themselves to be in good or very good health condition, health status, while only one person thought that their health was bad. 8 persons, 5.1%, were hospitalized at least once in the past year because of their chronic disease. Health status continued, so the participants used health center services mainly for managing hypertension and diabetes for that clinic. 1 patient had asthma, but also had high blood pressure. Another 2 had asthma, but high blood pressure and high blood sugar also formed part of their illness. And regarding heart disease, only 2 patients suffered from this condition, but they still both had high blood pressure. Herbal medicine use and access. So 97% or 98% of the study population admitted to taking prescribed medication, while 88.6 to 89 admitted to them taking herbal medicine as well. And most of the participants, which is 60%, took herbal medicine sometimes with their prescribed medicines, while 15% took them off, while 15% took herbal medicine often, 13% took it all the time. A majority of the population, which was 84%, used more than 1 herbal medicine, and 57% used only 1, while 5.7, used only 1, while 10% used none. And the 10% didn't use it because they weren't sure what they're supposed to use and if they can use it, so they just didn't bother to use it. So just a few of the herbal medicine that I put there, and while talking to them, they were using more than these. So there was a longer list that I had with others that they were using, which I thought that did better for them than the conventional medication. So the most frequently used herb was fever grass. The tree of life that we know, aloe and aloes, was less frequently used. It was like 29.1 and 29.7% respectively. And most of these herbal medicines that listed here was from their backyard. So for persons who are listening online, some of them that were listed were like fever grass, your soursop, ramgot bush, cinnamon bush, peppermint, aloe vera, tree of life, as I said, and there were many more that were used. So the interaction with the healthcare provider. So the questionnaire consisted of 3 sections. The sections were the 3 factors. We will go through them independently. The first factor was healthcare process. So 85% of the participants did not tell of their use of herbal medicine. And why? That's because they were not asked, hence they did not say. So the questionnaire which asked about their satisfaction regarding the discussion, we couldn't ascertain what it was because they were never asked. There was no discussion regarding herbal medicine use, and 89.2% of the population confirmed this. Hence, there was no opportunity to agree or have an idea of the healthcare provider's perception of herbal medicine use. And the herbal medicine was not discussed in any plan of treatment. So the doctor never told me, okay, I can use this because it helps with such and such. That was not discussed. So the other factor within the questionnaire was content and relationship. And we can now assume and come to conclusions from all the others that because there was no discussion between the primary health care provider and the patient, the majority of the study population states they were not comfortable discussing herbal medicine use with their healthcare providers. One, because they don't know how they will think about them. They may say, okay, why are you using that and you're supposed to use that? You shouldn't use that. So they just didn't want to tell them anything. So factors and their association with disclosure. Factors influencing the quality of communication between patients and the healthcare providers at the primary healthcare center shows that older persons, more than or equal to 65 years, 99.3% of them were significantly more likely to disclose their herbal medicine use than the younger population, which is less than 65. The study population of more than 65 years stated that they were somewhat satisfied with the discussion compared to the 2.9%, which was less than 65 years old. It can then be concluded that the level of satisfaction with discussion increased significantly with age. So the older you get, they were comfortable telling the doctor whatever was happening or what they were doing. So in conclusion, herbal medicine use continues to increase and gain popularity globally. And in Montserrat, there's no exception. People are on a quest to go natural and believe that herbal medicine that is derived from natural sources is safe to use and has little or no side effects compared to conventional medication. And we as healthcare providers or we as patients, we should know that majority of the medication that we get from the pharmacy is herbal-based. So even though we think it's conventional, yes, there's something to preserve it and to get it like how it is, but most of them are herbal-based. Taking into consideration the potential risk and adverse drug reaction that can occur with the use of some herbal medicine when used alone or in combination with conventional medicine, it is paramount that physicians be aware of any herbal medicine that their patients are taking and take the opportunity to counsel the patients on the potential risks and benefits, because there are some benefits. So recommendations. So physicians, as I just said, with little knowledge and lack of training and understanding of how herbal medicines work and its effect on health, can make an effort to enhance their knowledge and understanding about herbal medicine use, since most of their patients, with or without their consent, is using herbal medicine. An atmosphere of trust should be established between the physician and the patient, because if your patient comes to you and say, well, doc, I'm using such and such, and you bluster out on them, why are you using that? You're supposed to be using medication. Then they're not going to say anything. They lose your trust, and they will continue to do what they're doing, and you can talk cheese. They're going whatever they're doing. Right? So providers need to facilitate and share about what they know regarding herbal medicine. During visits, the client should be asked about their use, and it's important that you ask them every visit they come if they're using herbal medicine. And as I said before, counsel as necessary. There is also a need for in-depth investigation through roundtable discussions with healthcare providers to hear their views regarding herbal medicine use. Also, there is a need to organize focal group meetings to further ascertain why patients do not disclose their herbal medicine use with healthcare providers. And the saying says, healing yourself is the greatest comeback. The power of herb cannot be denied. And I would like to acknowledge these persons for allowing me to be able to complete my master's degree. And doing this, it was really an eye-opener the Government of Montserrat, Chief Medical Officer, Director of Primary Health Care, Statistics Department, Mrs. Jacqueline Garvey Henry, she was my supervisor, Miss Yvette Holder, a dear friend to me, and a lady that just took me under her wings, Miss Gretling West, Miss Naomi Joseph Foster, and Miss Yasmin White. That's my references. Any questions?
Floor is open for questions. We are going to go quite quickly because we are now a little bit outside of schedule. Could we have the microphone on the floor, please? Sorry.
Okay, good presentation, Nurse Jubri.
Thank you.
Yes, it's interesting speaking about herbal medicine. But of note, I didn't notice any mention of marijuana use amongst these patients. Yeah. So I'm wondering if that question was asked or if persons were afraid to speak about, if they were using it, if they were afraid to speak about marijuana use because of fear. Also, Caribbean countries are focusing, some countries are focusing on the benefits of marijuana. In terms of certain diseases, and also in terms of socioeconomic benefits to their countries like Jamaica, and also St. Vincent and the Grenadines. Jamaica, even when I was there studying in 2019, they were actually passing their bill to legalize some amounts of marijuana, and Antigua next door. So, were you able to ask the question of marijuana use, and what was the response amongst those patients?
Okay, so as I said, there was a larger list of medications that were there. I did ask about herbal medicine. Some would tell me, nurse, what are you talking about? But there are some persons who did say that I didn't put it in the study because nurse said, one patient said to me, nurse, I'm telling you this in confidence, you're not to tell nobody else, So yes, they are using herbal medicine. And the marijuana as part of their herbal treatment. And a lot of them will tell you, listen, it's working for me. And so when they say that to me, there's one patient, I said to him, okay, you're using it, that's fine. But what I want you to do is are you using it with the other No, nurse, I'm not using it because it's working for me. I'm not using any other medication. So I had him now be checking his blood pressure all the time, coming back to me and showing me, listen, you see, it's working for me. So yes, they are using it, and it is very prevalent in Montserrat. Some people tell me I don't boil it, I smoke it. So they are using marijuana as part of it.
Thank you, Nurse Jubri. It's quite an eye-opener. But there is something that I have regarding herbal usage. It's good to some extent, but we cannot quantify the use in the sense of overdosage. Because if somebody is taking a tablet, okay, I'm taking 2 tablets. But when it comes to herbal usage, there is no dosage. So you can see that a patient taking herbal could end up having a liver problem, kidney problem because of overdosage. So that is one of the things that even if they come to tell us that they are taking herbal medicine, we want to encourage them to know the amount of which they are taking. Because we won't say it's good for them, encourage them, at the end of the day, destroy them.
Right.
Thank you.
Okay, thanks for your comment, nurse. And I agree with you. However, the explanation that I give sometimes to my patients is that when God created the world, he created the world in seasons, right? Right or wrong? Right. So when we're doing things, we have to be able to do it with moderation. And you see, I grew up with my grandmother, which would tell me, oh, you don't drink so-and-so bush on full moon. Yeah, because it causes whatever. There are patients who end up with liver cirrhosis, and that is because they use, and one example is the neem. Neem is very good, but neem, when used too much, it causes liver cirrhosis. So when a patient come and say to me, I use neem, but I use neem, I tell you no, I tell them no, you cannot use neem every day. One, it sends your blood sugar low when you use it too much, and two, it causes liver cirrhosis. Yeah? The bitter stick that we know of, the bitter stick, they tell us to drink it, that's another thing. You cannot drink it every day. You end up in hospital because it sends the blood sugar way down, and sometimes it may be detrimental to you. And since I've been in primary health care, I've been working with Dr. Valentine, and when the patients come, they come with, most times they come and tell you they have arthritis. So Dr. Valentine, and I learned from him, there's a little remedy, and I read it myself, that you would put turmeric and your garlic and your whatever, make little capsules, and you can have that, and it helps with the arthritis pain and the anti-inflammatory processes. So there are natural things out there which really do work, but we have to be mindful how we take them.
Yes, thank you, Nurse Jubri, for your presentation. Very interesting topic. And it's something that's been around for many years. We all know, as I said, the grandparents would tell you what to do when you get sick, what to drink, which bush to draw, things like that. However, in this day and age when we practice evidence-based medicine, it's critical that these things are studied and documented. You have to have a dose-benefit ratio. You have to know how much to take, when to take, and so forth. And then after going through medical school for many years and working hard for a degree and a license, and then you advise patients to take this, that, and whatever, when adverse effects happen, then that's on you, and your license is gone. So there's a lot of studies that need to be done. I mean, in Jamaica, alternative medicine is a big thing now. Even at UWI, there's a branch of the medicine department dedicated to alternative medicine. So they're doing the research, they're doing the studies, and they can tell you for which conditions, what they use, how much to take, and so forth.
Right.
So persons go to those physicians who are specialized in alternative medicine. But until we have the evidence and the research here, we have to be careful what we say to the patients. And yes, we do ask sometimes, and the patients would tell you outright what they're using and say, okay, I would take my medications from the pharmacy this week, and then I take a break, and then I drink this, and I drink that. And we ask, okay, how much and so forth, is it working? So we do ask, and the patients would interact. And for some patients, yes, we would advise, okay, yes, we know that this works. The cinnamon, to help with the diabetes, and the moringa and so forth, we know that it helps, but it's for the patients to be aware how much to use. And I would say to them, even though you add these things, still maintain your medications, your diet, and your lifestyle management.
Yeah.
Yeah. So it has to be a well-rounded thing.
Thank you.
Okay, anyone with something heavy on their chest they want to share?
Okay, there's no. So I have just one observation, though. In terms of education, whether we're talking about educating people about the volumes or the amounts of the herbal medicines, it is also a fact in taking conventional medicine. I know I had a particular neighbor who used to say when she misbehaved, so at Christmas, for instance, she ate too much ham and pork and she had salty foods, she looked at the tablet they gave her for hypertension, and it was a small tablet. So she decided that this like a tiny pill can't possibly manage how high my pressure gone. So at certain times, she would take two. Despite all the best conversations about, no, you can't. Yes, she used to tell me, yes. When I'm good, I take one and the pressure good. So when I know I eat all the wrong things, I take two. So there's a window for education even with the so-called conventional medicine. Then imagine what it would be with the ones, as you say, who you have to tell about the non-conventional methods. So it is all about health promotion and health education at all levels. And let us not forget the legal aspect, whether we like it or not. We shall not leave this room today or be on social media to say that the chief medical officer and the director of primary health care in the room with you all agreeing about people using marijuana. For the record, marijuana is still an illegal drug
in Montserrat.
In the overseas territory of Montserrat. Thank you.
I just have one comment to add to that presentation before we break for lunch, and that is that it's interesting that you call it herbal medicine, because I don't necessarily think about these things as medicine. They're our food, isn't it? We cook with ginger, we cook with turmeric. When I go home and I brew a cup of fever grass tea, I don't necessarily think that I'm taking medicine, and I think I'm saying that to relate it to the way we craft our language when we speak to our patients. So maybe it's not just fair to ask them, well, are you taking herbal medicine? Because in my mind, the cup of tea, bush tea that I had in the morning, that's not medicine, that's tea. So it's very important for us to craft our language in a way that people understand when we are asking about what you're taking, you know, what you eat, what you drink is part of your quote-unquote medicine. So I think we can all say and agree that we had an exciting first half of intellectual presentations and stimulating intellectual discussion, yes? Yes. So we will now go swiftly to lunch. Can we have lunch in 40 minutes, do y'all think?
45 minutes.
Yes, so we will be back here at 2:15 for our afternoon session. So thank you for staying with us. Lunch has been provided for you here downstairs, and we will be back here at 2:15. And again, that is written in stone. No unexpected power outages. We'll break that this afternoon, fingers crossed. So see you guys soon. important. She also works at the forefront of our infection prevention and control program. She will be followed by a recorded presentation coming from Dr. Keneal Chrysostom. He's an internist, a nephrologist currently practicing in Jamaica. He did a tour of duty here, I believe, back in 2020. And during that time, he took an avid interest in kidney health for obvious reasons and conducted studies under that theme. His presentation, as I said, is pre-recorded. However, he will be available live for question and answer, so you'll see him right up on your screen there. And last but surely not least, this afternoon, we will have Dr. Shara Greenaway-Jubri, our Chief Medical Officer. And her role is a very critical one in that she manages the clinical operations of the Ministry of Health. It is undoubtedly a tasking job, but Dr. Greenaway-Jubri continues to rise to the challenge. And I think we can all agree that under her guidance, the quality of care provided continues to improve. So without further ado, I will now hand you over to Dr. Skerritt to lead us in this afternoon's session.
Thank you, Penny. Good afternoon, everyone. I know I'm coming after lunch, so there might be a little bit of stretching required. I hope everyone had a good meal and that we're ready to chat. So today we're going to be talking COVID. I know that it's a topic that feels overworked, overdone, but there's some new information and insight that I'd love to share with you. And so I've entitled this talk, Jab Culture, a conversation with the youth in Montserrat about COVID-19 vaccine hesitancy. So this project was funded by the Pan American Health Organization, and they were interested in finding out how young people across the region felt about vaccines, in particular COVID-19 vaccines. And so they're the ones who would have provided the funding for this project. I would like to say thank you for that opportunity. And of course to the Ministry of Health, from senior staff to all those involved. We had several activities which the staff fully engaged in. So thank you to all those who took part. The Department of Youth and Social Services assisted us, Youth Sports and Sports Services, assisted us in recruiting some assistants. I was able to host some focus groups with some young persons, namely the National Youth Parliament team, the Rotaract Club of Montserrat, the new recruits of the RMPS, Royal Montserrat Police Service, as well as members of the Defence Force. And of course, to the research day organizers, Abby, thanks for the assistance with analysis, and to those who put this day together, thank you for the opportunity. So what do we care about? We're going to do a quick background, look at the methodology for the survey, who was surveyed and why, and the general findings, a little discussion about vaccine hesitancy and what the participants had to say, sharing as well in detail the comparison between vaccination status and education level, and associations between their views and opinions on vaccines when related to those education levels as well, and how they want to learn about vaccines in the future. So the Strategic Advisory Group of Experts on Immunization came up with the definition that we know as vaccine hesitancy, and they've defined it as the delay in acceptance or refusal of vaccination despite availability of vaccination services. Now, what we've realized, and WHO has determined, that hesitancy to vaccinations is actually a threat to our global health. So persons delaying access or refusing vaccines is going to impact how we experience healthcare, for those of us who work in healthcare, for those of us who have chronic illnesses and other illnesses. It will affect us long term. And so it's in the top 10 threat in terms of global health all across the world. Now, the concept of vaccine hesitancy is not as simple as we'd like to think. We'd like to believe that, well, if we have a vaccine and we tell them that it's available and it's on the radio, then everybody should just line up and come and get their jab and go. But it's quite complex, and the context is almost always specific to the vaccine. It's not something that can be generalized, and it varies across times, places, and vaccines. We've learned that there are various factors that influence vaccine hesitancy, and they speak of the 5 C's, the confidence, how confident are people in the vaccine, are they complacent, is it convenient to access the vaccine? Persons, of course, calculate risk. Do I need to? If I don't take it, what will happen? And of course, the whole concept of collective responsibility. I'm doing it to protect those around me and not just myself. So the background. So knowing this, knowing that vaccine hesitancy is one of the global threats to health, PAHO said, well, we are examining our numbers in the Caribbean and they're not where we would like. And so they had a workshop last August and invited some young persons from different islands to participate. And stemming from that workshop, which was entitled Youth as Agents of Change, they asked us to come up with a proposal that would help to increase awareness or determine what our hesitancy levels were across the region. The initiative sought to train and empower young persons to be a part of the change and want to assist in what was happening with the COVID-19 response. And the survey was one element of the project. We also had several focus groups. You might have heard some of the radio testimonials on ZJB with young persons sharing how they felt about the vaccine, what their experience was. We also had a live chat that some of you caught on YouTube with various young persons sharing how they think the way forward should look for Montserrat now that we're coming out of the pandemic. And we held a vaccination and wellness drive. And I see a few familiar faces from the drive. So those young persons in our departments who were there, from lab staff and others who participated, thank you. So who did we survey? We sent out the survey to those 18 to 35-year-olds who lived on Montserrat. And it was digitally circulated using a Google link. We were assisted by the HRMU because we know that there are lots of young people who work for the government of Montserrat. And some 332 persons who work for the government fall within this age category, and so we sent it out to them via email. We also circulated QR code posters that we posted in public areas, government health centers, and stores, and circulated, of course, digital versions on WhatsApp and other media for easy sharing and for clickability. So how many people? Sent out a whole heap of surveys, and we had a total of 66 participants. This was broken down into 38 females and 28 males with a minimum age of 18 and maximum age, of course, of 35. The mean age of those participating was 26.3, 26.1. And we had 45% of that sample being female and 55% of that being male. In terms of breakdown, 45, right? In terms of breakdown, just for you to see, we had broken it down into those who were vaccinated and those who weren't. So we asked, are you vaccinated? And of the females, 38 who participated, 17 of them were not vaccinated, that's 45%, and 55% were vaccinated. We also saw majority of those males who participating being vaccinated, 82%. And so the total vaccinated among the group surveyed was 66%, 2/3. So of every 3 people, 2 of them were vaccinated in this age group for this surveyed group. What was the breakdown? Thankfully, we had some diversity. We had persons who were born in Montserrat. We had those who were born in Dominica, Jamaica, Guyana, some from USA, 1 from Haiti, 1 from UK, and another group. So quite a diverse bunch who responded to this survey. Of the group surveyed, 53% of participants declared initial hesitance. So we tried to find out, okay, yes, you might have gotten vaccinated eventually, but initially, were you hesitant? And ask them, of course, to share why and what influenced them. There was no real difference between male and female for those who were initially hesitant. The split was 57% male and 52.6% female. And of those who were initially hesitant, 53.3% went on to be vaccinated. And so the question was, what changed their perspective? What was the major thing that shifted or influenced them from being hesitant to making the decision to get the jab? Majority, in terms of expressing their reason for hesitance, listed lack of trust in vaccines due to the speed of development and concern regarding side effects as reasons for initial hesitance. 15 participants who were initially hesitant went on to give a reason for why they changed their mind regarding vaccination. And the majority of them cited the number of deaths related to COVID and personal research as the main reasons for changing their viewpoint. I know this is kind of small, but it basically reflects the proportion of vaccinated persons by highest level of education. Now, in the first column, we have secondary education, second column community college level, sorry. The third column represents Bachelor of Science, and the final column represents Masters. So for those surveyed, we asked their education level, and we attempted to correlate this in some way to their vaccination status. Now, it's important to point out that although the preliminary results show a trend that suggests that vaccine uptake may be associated with education level, the observed difference between the groups is not statistically significant. So bear in mind, the sample is small. There were only 66 participants. And so some of this data cannot be generalized, but it provides some insight. So in order to confirm or prove that correlation, the survey would have to be expanded and we'd have to redo it for a larger sample. So what were their views and opinions? Because we know that young people have a lot to say about vaccines, now more so than ever, and it's easier for them to share this via social media. And so to understand if vaccine hesitancy was higher in those with less knowledge about vaccines in Montserrat, the survey included a series of true and false questions in relation to vaccines. What we found based on these true and false questions were that more participants with a lower level of education answered these questions incorrectly when compared to those with a bachelor's degree or higher. For example, when asked if the following statements were true, all of those who selected incorrect statements regarding vaccination also admitted to being vaccine hesitant. So we see some correlation between hesitance, maybe the level of knowledge about vaccines and their general education level. Among the vaccinated and unvaccinated youth, we would have asked their preferred method of learning about health-related data about vaccines. So if you wanted to find out information that you considered to be true, factual, and real, where would you want to get this information, and what forum would you think most appropriate? Among both the vaccinated and unvaccinated youth, they believed that focus groups and workshops were the preferred method for receiving health-related or vaccine-related information and thought that these were trustworthy sources. They also actually had radio programs and news as one of the higher-ranked sources of data, but listed things like social media, WhatsApp, Instagram, Facebook, and Twitter lower down. And you know that during the pandemic, there were attempts to do a lot of social media type pushing. However, within this surveyed group, they still seem to lean towards close encounters, focus groups, and discussion areas as their source of information that they thought they could actually trust and believe. So what can we conclude? We know that vaccine hesitancy is complex. We know that it predates COVID. COVID-19 is not the first time we've seen young people or anyone being hesitant towards taking a vaccine. We also accept that in Montserrat there are varying attitudes because we have a large number of young people, 2/3 of those surveyed being vaccinated, but expressing at least initial hesitance towards having the vaccine. We also know that with samples this small, it's difficult to draw clear conclusions about hesitancy. However, we know that it will provide some insight, and so we have a better idea of maybe how to approach it, which markets to use, and how we can share information in the future. It is important, however, based on this survey, to address the misinformation that may be contributing to vaccine hesitancy, and as well to accept that there may be some relation between those who are not as well educated and those who are more educated, and to account for these gaps in how we market, in how we share information, and choose as best as possible those methods and channels that are preferred by that group and by the populace. And that is all. Any questions or comments?
The floor is once again open for discussion. Our microphone is roving and ready. So who wishes to go first? Dr. Hazel, is that your hand? Yeah.
Yes, sister has a question or comment.
Very interesting presentation, Dr. Skerritt.
Thank you, sister.
I'm just wondering, it's not a question that I think you'll be able to answer, but do you think that the reason why, because the majority of the young persons who participated, they were vaccinated, when the national vaccination level, I think, was around 40-something%.
Yes.
So do you think that the majority of those who did not want to be part of it, was it because they were not vaccinated that they didn't feel like they wanted to share that their
status
and among other things?
Yeah, so that's a good point. So the question is, do we think that those who were unvaccinated were maybe not willing to participate because of their status? That could be a factor. One of the things looking back now in retrospect is that we did majority digital marketing or digital promotion, and we did not provide hard copies for persons who may not have had access to devices. So that was a limitation coming out of the survey in terms of data gathering. So that was a limitation that we would have accounted for. So that's a very good question in terms of other research. So actually tagged to this survey at the end, although it's not related to COVID-19, I did have an interest in finding out views about HPV and what persons knew about HPV vaccines, what they thought, what cancers were associated, whether they knew whether Montserrat had the vaccine available or not. And so that provides room for a further discussion on HPV and how we're treating, not really treating, but how we're managing, what our pap smear numbers look like and how that might correlate to those numbers. So that will be the next thing that should be discussed or will be coming out based on this initial survey.
I was going to say that I believe that the findings from Dr. Skerritt's research should make our minds start to tick, because vaccine hesitancy is not just a thing with COVID-19. But those of us who, however you feel about the COVID-19 vaccine, it's another matter. But there are the ones that were considered routine vaccines before, childhood vaccines, that in certain parts of the region, the hesitancy is increasing. And we may seriously need to consider how do we use that approach and others to figure out what is happening. We have a lot of young parents who have children that are in the ages in which we would normally do, the routine vaccines, and we may find ourselves with some other serious consequences, one way or the other, that need to be addressed. So I think we shouldn't take it lightly. It's not just about COVID anymore, it's about other things.
I think that's a very good point to make. And so one of the things I discovered, I actually didn't know this, is that vaccine hesitancy can be dated back to as far as the 1700s. With smallpox, when the first person said, this disease we have, maybe there's something we can do to prevent it. And so with every wave of contagious disease, we tend to have some level of vaccine hesitance. One of the things that really assisted, or one of the things I observed during this project, was outside of the whole survey, when we did the focus groups with young persons, there's a very clear interest in vaccines and wanting clarity, especially because of the amount of misinformation, especially because there's so many persons who have an opinion on it. And even in our discussions in those focus groups extending towards HPV, the whole conversation that, we didn't know that there was a vaccine that could prevent a particular type of cancer. We didn't know that it was available for a particular age group. And some of them were parents, they were young parents. And they said, well, if I can do something to prevent my child from developing cervical cancer or anal cancer in the future, sure, is it something they have at St. Peter's where they can get the jab, So there's that interest once persons are well informed. However, I think our approach has to be a little bit more personal, and the opportunity, I guess, goes back to our districts where that relationship already exists, not to put pressure on the DMOs, not to put pressure on the district, but because persons tend to trust their GP, tend to trust their nurse in the community, the conversation is a lot easier to have at that level, I think.
Just two quick points. I wondered whether there was any connection between your presentation and the previous one about herbal use, and whether the young people, any of them came up with that to say they prefer to use natural remedies and the chemical ones. And the second point is did you do a literature review to that? Because I'm interested whether there's a stronger link elsewhere between educational level and vaccine hesitancy.
Okay, so to address the first one, the survey did not include questions about whether they were using herbals as an alternative. However, I know at the focus group level, a lot of them would say, well, they know from the young, their granny tell them this work for cold, and if COVID is a cold, then they can use that. Not so much as a preventative method, but to say if they got sick, that's what they would use. Right. In terms of a literature review, for this purpose, what I did, it wasn't so much about well, the literature review I did was limited more to youth, not hesitancy, but vaccination rates across. And what we found is that, yes, we are at, well, for us, roughly the 66% in that range. But in other countries, because of the type of mandates that were enforced, especially early on, their rates were a bit higher because it was being tied to things like work, and it was being tied to like access to certain things. And so their rates were more in the 80s to 90s. However, you know, we have our challenges, and it's something that we can grow and learn from.
But the connection between education level and our and vaccine
And our rates. Well, there is a connection between education level and vaccination rate. It's something that has been studied and is supported. As I said, it's hard to generalize, but we saw some signs that there may be a connection. But there's room, I think, with this, if I were to do it again, or to try to expand it, then there would be room to find out for sure if that's a true connection or if it's not that significant for us. Yes, Mr. Ho?
One last question.
Somebody else have a hand? No, I was just going to make a comment that I know that in terms of some persons may be hesitant to vaccination, but when they need to travel for study or they need to travel to the US, and there are different requirements that for vaccination, you can't get the vaccine fast enough. And I know that for persons who are going overseas to study, there was a mandate from the HRMU in terms of for their protection that they need to be
vaccinated.
From UE? Okay, okay, but that persons, they have to be vaccinated.
Yes, so that is true, and you know, part of the conversation of vaccine hesitancy goes back to motivation. What is it that makes one person choose to or choose not to?
Yes, because all along they will be resisting and say, I'm not taking this, and then
you have to take it in order to enter.
Yes,
yeah.
Travel purposes and
education purposes.
And education.
Mr. Howe.
Yes. Quickly, a very good presentation. Just an observation. You know, during COVID, there was this discussion about, a lot of the information that caused the hesitancy was related to what was on social media. And I think it's always important to take on board studies that now suggest that really it's not what we think. It's going a little deeper and find out what is the real situation. Because here you're now saying that, hey, people now need to get a little closer to people, one, in terms of the radio programs, in terms of the consultations. Because one of the things I recognized, too, was a lot of people were depending on someone who they trusted to make a decision for them. All right? And I think that the way we now market the information, how we go about educating the public is going to be significant in terms of getting closer to people, find out where they are, so at least you can have the kind of outcomes that you want. So I think the study is useful, and perhaps this is one of the reasons why more people should have been a part of this, just to understand how significant it is. And so I'm not somebody who normally goes around and try to be a part of a study, but now I think I will be in the
volunteering for future studies. Fantastic. Thank you, Mr. Howe. Just in response. So yes, I do think there's a role for the more personal approach. I think for me, of all the projects we did, the vaccination and wellness drive, we had conducted it at Braids, and we had, you know, the participants were on the older part, but that's okay. Those who we had in the focus groups, they took the time, they were happy to have somebody come in and take all the questions, of which there are many questions, and there's lots of repetition, and there's lots of persons who think and heard and are not so sure, and just wanted the reassurance or wanted a clear voice. You spoke about literature review. One of the studies I reviewed out of the UK shared that one of the counties basically realized that they had poor uptake. And so they invited GPs, they collected numbers for those who they realized weren't taking the vaccine, and they asked their GPs to make a call, or staff from that particular surgery to make a call, and have a conversation with those who had refused the vaccine for whatever reason. And they found that after those calls, the persons who might have initially refused opted in. Might be the role we play, might be the role we play, might be the role we play, might be a little bit more play, might be a little bit more play, might be a little bit more personal, maybe the broad brush posters. Like, I love to share a poster, I love to share a flyer. I hope that people read when I screenshot and share things that are health related on my status. But sometimes a conversation goes a long way. Thank you.
And I'm very excited to hear Mr. Howe say that he's ready to be part of our vaccine initiatives. And while we smile about it, it really is a critical area that needs support. If you were to just go into Google now, you'll see that polio, which was almost eradicated, is now on the uptick in many places. And it's because vaccine hesitancy has taken root to the point that people are not getting their children vaccinated anymore. And we would absolutely hate for that to happen here in Montserrat. So I'm very excited that Mr. Howe will be on board to lead the charge, along with, of course, Dr. Skerritt and others, as we try to address the issue before it becomes an issue. So we're now going to have a presentation by Dr. Chrysostom. Just to remind you, it's a pre-recorded presentation, but he will be joining us for Q&A. So pay close attention and remember to jot your questions down.
Good day, everyone, and thanks for stopping by. Good day, everyone, and thanks for stopping by. My research is entitled The Prevalence of Chronic Kidney Disease and Associated Risk Factors on the Island of Montserrat. The picture you see is a very prominent and unforgettable feature of the island, the La Soufrière volcano. Montserrat is nicknamed the Emerald Isle of the Caribbean, and it is a British overseas territory comprising part of the chain of islands known as the Lesser Antilles. It comprises a population of just under 5,000 people, which is predominantly African, with smaller percentages of Hispanic, Caucasian, Indian, and mixed. As at January 2020, the burden of chronic kidney disease in Montserrat remained unknown, on an island that to date has no facilities for renal replacement therapy. We sought to determine the prevalence of chronic kidney disease among patients attending ambulatory centers on the Emerald Isle and assess its distribution by age and gender. We also sought to determine the etiology of chronic kidney disease and the prevalence of associated risk factors. A cross-sectional observational study of eligible participants was performed, inclusion and exclusion criteria to the right of your screen. Random cluster sampling of at least 500 participants who attended ambulatory clinics from January 1st to July 1st, 2020, across all primary healthcare facilities on island was performed. The main outcome measured was estimated chronic kidney disease prevalence, defined based on KDIGO guidelines and using the CKD EPI formula for blacks and the estimated prevalence of CKD risk factors, being self-reported diabetes or hypertension and obesity defined as a BMI over 30 kilograms per meter squared. Multivariate logistic regression was used to determine independent predictors of chronic kidney disease. This table includes participant characteristics and chronic kidney disease findings in Montserrat for your perusal. Of significance, we noted that Montserrat is an aging population, with the average age of participants being 63 years, and 60% of those participants were female. 38% had self-reported diabetes and 58% had hypertension. 44% of the participants were obese. The mean GFR, or estimated GFR, was 81, and 25% of patients had an estimated GFR in keeping with chronic kidney disease. With respect to the independent predictors of a reduced eGFR, age, self-reported hypertension, and being female carried a higher risk of developing chronic kidney disease in this population. Some points to note: the disparity between males and females did not reflect the island-wide gender distribution, which showed a 52% male majority, and this may have been due to females typically having more willingness to participate in health-related activity. We see a need, therefore, for health promotions designed to target the male in the population to dispel this seemingly cultural norm. Despite the overall prevalence of self-reported diabetes being the highest at 58%, age, hypertension, and female gender prove to be independent predictors of a reduced estimated GFR. Blood pressure control in this population is therefore of high importance in slowing chronic kidney disease progression. One limitation identified was we included screening for this study to high-risk individuals. Population-based sampling of participants was not done. Thus, we may have detected a higher proportion of individuals with chronic kidney disease and its risk factors than would be obtained in a population-based sample. Lastly, the burden of chronic kidney disease and non-communicable diseases poses a significant financial strain on the health sector, and there's need for development of an integrated system for data management, promotion of primary prevention initiatives, and the utilization of community health workers. These are just some of the recommendations for reducing the burden of these diseases and, in turn, slowing the progression of chronic kidney disease in the population. And that's my presentation. I would just like to thank the following persons for their invaluable contribution in making this study possible.
Okay, so as I mentioned, we'll be getting him right here on Zoom in 5, 4, 3, 2, 1. You should see him there shortly. Just bear with us. Sometimes technology can be tricky. I don't know if any of our technicians know what to do. Okay, there we go. I think that's going to be it. Start video. Pardon? Turn on his audio. Dr. Chrysostom, we see you. Is it possible for you to turn on your audio so that you can speak with us? And we can get the microphone ready for questions. I know our CMO, she was eagerly anticipating this presentation. She mentioned it in the morning. Okay, we see you, Dr. Chrysostom, but your microphone seems to be turned off. Is it still red? Can you hear us? Blink twice if you can hear us. Doesn't appear that he can hear us, so just give us a quick second. We will be there shortly. You know, technology is such a wonderful thing, but for folks like myself who sometimes are clueless, it's a great challenge. So he's hearing us now? Whoa, wonderful, wonderful. Yes, so Dr. Chrysostom is here and he is ready for our burning questions. So who would like to go first? So I'll start the ball rolling. I'll ask a question based on your findings. We have quite a large population of people with diabetes, hypertension, and we know that this relates to kidney failure. Did you find that enough screening was being done in terms of frequent laboratory tests and whatnot to, when you went through those patient profiles and whatnot, was enough screening being done of those patients as it relates to their kidney function? Hold one moment, we're trying to get your volume up. We're getting there. You can go ahead. You can go ahead now.
Okay, I trust
Wonderful.
everyone is hearing me now?
Yes, perfect.
Okay, so good afternoon, everyone. I'm really happy to be a part, albeit virtual. And thank you for your question, Penny. With respect to screening, what we should identify is the fact that this study was done in ambulatory centers, so health centers, on patients that already had established risk factors or comorbidities for chronic kidney disease. So based on the population that was studied, it was just about 8% of the total population, which would not reflect the overall, the nationwide prevalence of chronic kidney disease. So that's one. It simply highlighted that among the high-risk patients, there is a pretty high prevalence of chronic kidney disease, and those patients were being monitored fairly well. We had labs at least every 3 to 6 months, and there were issues with the urine studies, but we had gotten the machine that would detect albuminuria. So for the most part, from a lab point of view, we're pretty much doing okay in terms of the risk, the risk at-risk population. To do a nationwide screening or a nationwide study would require a lot more testing, and that is just something that we could probably put as a plan to eventually screen a representative population of the entire country, because as you would have seen from the data, a lot of the high-risk population is elderly, so over 60 years old. So it would be a good idea to do a nationwide screening where you incorporate patients of all ages from 18 to 25 or 18 to 35 and 35 to 60, like the working class, and then we could have a better estimate as to what the nationwide prevalence of chronic kidney disease is. So there's still work that could be done in that regard.
Thank you. Any other questions from the audience?
So while we're coming up with questions,
We have
another
one
thing
here.
that
We have
was
two here, two hands that I see, but go ahead.
okay, I'll take them.
You can go ahead with your comment as we get the microphones to
Yes,
them.
what I was saying is what we found interesting, so much so that so the data was actually published in an abstract last 2 years. But what we found interesting that prompted a reanalysis of the data was the finding that the main factors that contributed to chronic kidney disease were age, which wasn't that surprising, hypertension, which is in keeping with the rest of the Caribbean, but female gender. Female gender was a bit of a surprise to us, so much so that it prompted a reanalysis of the data. And upon reanalyzing all of the data that was gathered during that time period, the same three factors stood out. So it raises some questions as to, what could be accounting for the female prevalence of chronic kidney disease, and that is an avenue that we'd probably like to dig further, if there's any environmental factor or anything contributing there. But that is definitely in the cards in terms of future work, which we will pursue.
That's an interesting and slightly concerning finding, and I look forward again to the studies being done there. I saw two hands. Can we start with Dr. Skerritt, Dr. G. Skerritt?
All right. Good afternoon, Dr. Chrysostom.
Hi.
Hello. All right. So I just want to say thank you for your work. You were with us for a short time, and you did an important study for us. So thank you for that, and it gave me an opportunity to assist you with your data collection and so forth.
Sure. And thank you for your help as well, because you were a part of it, remember?
You're welcome. So with this study, it's highlighting the importance of renal replacement therapy and having resources available here in Montserrat. So as you said, the patients are already coming to the primary healthcare centers. So we see them often, we do the testing, we do the screening, and we pick up these things, we pick up the proteinuria and so forth. And then we say to them, okay, we're seeing that you're showing you're developing chronic kidney disease, but then what do we do now? So that's always the challenge. Even recently, I had a couple patients who they're at like stage 4 chronic kidney disease. We don't have any replacement, here. We're just monitoring, trying to help them with their blood pressure control, diabetes control, and so forth. And we have the option of telemedicine support. However, that's at a significant cost as well. So I spoke with CMO, we mentioned the cost to the clients, and they were just like, nope, they cannot afford that, and they cannot afford travel to the UK. They don't have any support for family in the UK to say we can get them there so that they can get treatment. So it's a big issue in that, yes, we do the screening, we can pick up who has chronic kidney disease, but then we just can't help, and it's very frustrating. So, but even in the Caribbean region, it's a heavy burden in Antigua. They have no spaces to help us there. Jamaica has a lot of renal clients as well. So it's what do we do? How do we get our health advisors and the UK on board with helping us here?
Well, thank you for that thorough overview, Georgette. I think the main issue when it pertains to screening is, I guess, our perception of it in a sense, because screening is going to identify cases that are at risk and patients that have developed early features of kidney disease, right? Now, if we identify cases early, then the focus would be on slowing the progression so that when we get to end stage, there would be at least enough, call it preparation time for transitioning to further treatments, right? The issue that we're trying to mitigate is somebody showing up to the accident and emergency department and they're at stage 4 or stage 5 and they need treatment urgently, and then it's it's a rush to get them medevaced for further care or to arrange with family members in the UK to kind of get them off island for dialysis and stuff. So although the infrastructure is not there for renal replacement on Montserrat right now, at least if we could identify the at-risk population and do a general projection of how fast these patients should progress or what's an estimate. So, for example, in the next 5 years, we expect X amount of people to be at stage 4, stage 5. In the next 10 years, we expect XYZ. So that, I think that would allow the Ministry of Health and Social Services to maybe put, they'll have tangible data to work with so that we could put things in place for that projected time rather than putting a system in place where we're not sure if it will be underutilized or if it would be absolutely necessary at this point in time. So the nationwide prevalence would be good information to plan what we do going forward.
Yes, thank you. See another question?
Yes, good afternoon. So merely a comment. I want to say thank you to Dr. Chrysostom, if I got it right. Yes, I want to say thank you to you for your initiative in doing this research, because we do have persons in the UK who are on dialysis, would want to come to Montserrat, but they can't come because we do not have the facility. We also have persons here on Ireland who, based on what you have found and also from what Dr. Skerritt is saying, who may need dialysis, but you also have those persons who when they think of going to the UK for dialysis, that's it. They cannot come back home. And so the study you have done, and I think as you mentioned about a wider study across the island in terms of doing more research across the population is a good one. And it also probably may prompt government in terms of, based on the findings, of seeing how we can access that dialysis unit on Montserrat, maybe one or two. There are persons who have been talking about it before in the past of getting that set up here, but it has to take a lot of work in terms of having the research done and putting the necessary things in place. And I believe Dr. Greenaway is looking into all of that. But in the meantime, the research is what is going to help us to get to that next step or the next level. So I want to say thank you for your presentation. I think it's a good one. That's my comment.
Oh, thank you. Thank you. And yes, I fully agree. With more research, we definitely will have a basis and a framework that we could kind of structure because having a dialysis unit, it's potentially a big undertaking, not just to put it in place, but at least we would have an idea of, what the numbers are like, so we'd know exactly how elaborate or how many machines and when it would be needed, that sort of thing. So at least people in the UK that want to come home, like you said, would have the opportunity to come home and know that there's a unit in place that they could receive their dialysis while on island.
I'm sorry, Penny, can I just ask a very basic question, though, for the benefit of those among us who may not necessarily be clinically minded or for those who are viewing? I hear a lot of reference to stage 3 and stage 4, and then I heard words like renal replacement, whereas the average layperson understands dialysis in the sense that, could I ask you just very briefly, at what point is dialysis usually required? At what stage, for instance? I'm assuming kidney disease has stage 1, 2, 3, 4, but at what point is it recommended? If that's a straightforward question.
Okay, so there are 5 stages of chronic kidney disease, and this is based on a calculation made using your creatinine level. So when you do your labs, the creatinine, we use your age, your gender, and your ethnicity. And that is plugged into a formula, and you get your filtration or your level of clearance. And your stages of kidney disease are based on the level of clearance. So stage 1 would be a clearance of over 90. Stage 2 would be a clearance of between 60 and 90. Stage 3, which is when you say you have chronic kidney disease, usually it's between 30 and 60, and that is divided into 3A and 3B based on the clearance. And stage 4 is between 15 and 30, and less than 15 is stage 5. Now, when you get to stage 5, you look for the symptoms that are associated. Call it uremia. So you look for things such as the changes in appetite, changes in your mental state, itching to the skin, nausea, vomiting, decreased urine output, weight loss, and a very low blood count that can't otherwise be explained by anything else. Those features, you would usually call them uremic symptoms. So somebody at a stage 5 that has uremic symptoms is somebody that is approaching what is known as end-stage renal disease or end-stage kidney disease. And usually between 0 and 15, which is stage 5, when the person gets to about 7, a clearance of 7 or 8, that's when these symptoms begin to surface and they become more evident. So there are people that are stage 5 and they are comfortable and they don't need dialysis, but there are people that are at stage 5 declining in kidney function, and when they get to around a clearance of 7 or 8, you find that they start losing a lot of weight, they don't have any appetite, they're vomiting, they're nauseous. Simple things like the food start tasting different, start taste like a metallic taste. They're more aggressive or more tired than usual. Those features, once you start developing those, you would say the patient has transitioned to end-stage renal disease, and it is at end-stage renal disease that you start dialysis. Now, it would be different if we were in the US or even the UK. Sometimes you get to stage 5 and they start their patients at stage 5 regardless, right? And it could be a matter of they have the resources to do that, but there was actually research done on when to start patients on dialysis. Is it when they get to stage 5 or when they begin to have symptoms? So they had a study comparing the two, and what they found is that there is no difference in how long these patients live if you start them at stage 5 or when they develop symptoms. So it's simply just a matter of opinion. It's actually a paper in the New England Journal of Medicine. It's no hard and fast as to when you start dialysis, but in the Caribbean, especially in resource limited settings, we usually start them when they begin to develop symptoms, which will be around clearance of about 7 or 8.
Thank you.
Thank you. Any further questions or comments from the audience? I see 2 more hands, so those will be our last 2 questions for the afternoon. Go ahead, Dr. Greenaway.
Yeah. Hi, Dr. Chrysostom. Dr. Greenaway.
Hi.
Hi. So thank you very much. Presentation was excellent, as usual, and as expected. My question is, because from the Ministry of Health and Social Services standpoint, dialysis is something that we're looking at. And as I mentioned earlier today, Penny would have mentioned it to the group. I mentioned about your study because there was a presentation about not having dialysis and patients succumbing because of that, in terms of being a critically ill patient, and that was one of the interventions that were required. The importance of having data to drive decisions and offer that justification for implementing this intervention. But one of the things that I would say to the policymakers is that while we think about dialysis and what we need to put in place to start that, what is your view on starting dialysis without developing a pathway to kidney transplantation? Because it's almost like you start your dialysis unit and you end up spiraling into this very expensive intervention without having a proper endpoint, if I use that for lack of a better term. I remember sitting in a regional conference and we were talking about dialysis and the different countries that were having issues with their dialysis units. They are expensive to maintain. You have several specialists that you need to have on board because persons think that dialysis is something very simple, right? You set up your unit, you have your machines, you hook your patients up, and then you just put them on a schedule. But it's not as simple as that. You need doctors like Dr. Chrysostom here who are specialized in nephrology. You need nurses that are specially trained to operate the machines and take care of the patients. And also, patients who are on dialysis, they tend to have higher hospitalization rates. They tend to be very ill. There are complications. The arterial venous shunting that you need to create to hook you up to the dialysis machine, that is something that you also have to look at. Where are you going to send this patient to have the shunt done? And who's going to help you maintain it? Because they have issues with that as well. The areas get infected and so on. So as the CMO, I hesitate to start the dialysis conversation because in my head, I'm thinking about all of these things and also about that, not necessarily an endpoint, because when you have a kidney transplant, that's also not an endpoint. There are issues with that as well. There are donor lists, who you're gonna get your kidneys from, the donors, and also the quality of life of that patient after getting that donor kidney and the medications that they have to be on. Is that something that we can source and sustain in Montserrat? I'm sorry that I'm rambling and bringing up all of these issues, but what is your perspective on the whole kidney transplant aspect of it in terms of starting your dialysis unit and having a pathway to that?
Okay, so first of all, I think your analysis of the entire scope of dialysis and transplantation was brilliant. I think you raised a lot of the issues that won't just plague Montserrat, but even where I am in Jamaica right now, there's a significant burden of dialysis patients in terms of the amount of funding that is required, because like you said, they are a lot more morbid, so they have more frequent hospitalizations, and even in the setting where in Jamaica there have been attempts to revamp the kidney transplant the service. We have so far transplanted just about 7 patients, and the assistance for that comes from overseas. There's a team of transplant surgeons as well as nephrologists that come from Birmingham that usually assist in doing transplants probably once or twice for the year. In the ideal setting, transplant should be a bridge between end-stage renal disease and between dialysis and end-stage renal disease and subsequent transplantation. The issue that it raises is that there also needs to be quite a bit of infrastructural changes in terms of developing like a donor program. So when I say a donor program, I mean, well, obviously we'll start small, but as it pertains to even testing to see if candidates could be an eligible donor for someone, it would require outsourcing labs, outsourcing investigations that would be needed before making a decision. And the medications, the immunosuppressants that would be needed after transplant, that poses a major challenge, in Jamaica. Trinidad has an elaborate, established transplant program as well, but I mean, even to source your immunosuppressive agents, it takes some investment on the part of the government. And in a resource-limited area, well, particularly as we speak about Montserrat, the road to transplant may pose a lot more challenges in the short term. It would have to be a goal where there is some form of alliance with the UK, because even at this stage, I think the only Caribbean island that is able to do transplants without any foreign assistance, so to speak, is Trinidad. And their program has been going for quite some time, as early as 2008, 2009, which, I mean, is about 15 years. And they have done over 120 transplants in that time. So there's a lot that needs to go into the conversation when we're speaking of transplant. So for the most part, if we want to set up dialysis in Montserrat, it would really have to be more like an emergency basis, or as a means of a temporizing measure until further investigative workup for transplant could be done overseas, or persons that are living in Montserrat, they would be able to access these services and not have to consider uprooting their entire lives to go to the UK just so that they could be dialyzed. So there's a lot of steps involved when we're speaking of transplantation, and I don't think that it could be something that is independently established. It would definitely require assistance from the UK.
Yes, one last quick comment.
Thank you very much for your presentation, Doctor. And I'm not going down the road of dialysis. I'm looking at our public health approach, because for this morning we've had presentation about childhood obesity. We've had presentations about the level of hypertension and diabetes within our community, and now you're telling us about dialysis, which we need to look at our whole health promotion strategy in terms of preventing, how we actually reach our population from the very young, so that, instead of putting this burden, the quality of life and so on, when persons have to really go down the road of dialysis. So thank you very much for your presentation, and I hope that the ministry will use it as a teaching, if you have to instill fear that people don't want to get sick to go down that road. Thank you very much.
Right. Yes. Thank you, and thank you for your comment. I agree. We definitely need to start even promotion in schools about healthy eating, and that kind of stuff could be a step in the right direction.
Thank you very much, Dr. Chrysostom, for taking time out of what I'm certain was a very busy schedule to spend some time with us this afternoon. Your presentation was certainly very thought-provoking, and the discussions prove that. So thank you for joining us.
And thank you for having me.
Yes. Bye. Okay, so we have reached our final presentation. Do you guys need to get up and move around and have a stretch before we go on to the last? I see people looking tired. So just for 5 quick seconds, hands up, out, let's all get ourselves prepared to end the day with a bang. And taking us out of our presentation is our 10th and final presenter, Dr. Shara Greenaway-Jibri.
All right, good afternoon, everyone. Dr. Shara Greenaway-Jibri, I'm the Chief Medical Officer for the benefit of those online. And today I'm tasked with presenting the results of the Household Health Survey that was conducted in early 2022. And I would just like to say, I hope that you enjoyed the presentations from today. I think Dr. Hazel Blake scheduled me for the end for a reason, because now we're looking at what we found in the community, so island-wide. The other studies would have looked at specific populations. And so I think that this is really nice that we're just going to cap it now on the end. And I promise you that my presentation is very short, so we won't be here for much longer. So by the title slide, you can see that this was done in conjunction with the UK Health Security Agency, along with the Ministry of Health. This was actually presented at the UK HSA Health Conference, the Public Health Conference last year. And so we're using the same presentation. Also, some of you would have been involved in our NCD gap analysis workshop. This was also presented in that forum, so you might be familiar with some of the slides. And also, I would like to thank Ms. Adele Springer, who was the epidemiologist posted in Montserrat at that time from UK HSA. So, as you remember, 2022, we were still grappling with COVID-19. We had a very large outbreak at the time that this study was being done. And so I just want to point out that it's still possible to focus on other things while you're dealing with an outbreak. So this study is a tenet of that. So we wanted to reprioritize and focus on NCDs, and we wanted to include things like mental health, because that's also a priority for the ministry. And as you would have noticed in some of the presentations earlier today, persons were not able to speak about community-wide prevalence of non-communicable diseases, and so that is what we aimed to do with this survey. We also looked at certain risk factors like smoking and alcohol consumption, so I'm really excited to show you the results of that. And we're hoping that, well, we will use the information to further guide the policies that we make and to guide further investigations. So, who and what is of interest? For our inclusion criteria, adult residents over the age of 18, and we aimed to have persons who resided in Montserrat for at least 6 months in the study period that we're looking at, so January 2021 to 2022. And that's because we have a transient population. So we have certain persons who live like in the US and the UK, and they come and they live in Montserrat for like 3 or 6 months out of the year. We wanted to ensure that we were interviewing persons who were really living in Montserrat for an extended time and were more likely to access our health services. Exclusion criteria, as I mentioned before, visitors, anybody less than the age of 18. We excluded prisoners as well, and persons who were physically or mentally incapable of giving informed consent. And we asked persons about the number of people living in the household and how many of them were adults. We asked about NCD diagnosis, mental health and well-being, and alcohol, tobacco, and cannabis use. It was a cross-sectional survey, and the sample size was calculated based on certain assumptions and simple random design. We actually used the Australian Bureau of Statistics calculator to determine that. We also used ArcGIS mapping to plot the households that we were going to use. So we used GIS as well as GPS points. And we had to later add a few more GPS points because of the issues that I'll highlight them later on. Also, we developed the questionnaire on Kobo Collect, and we did the questionnaire in both English and Spanish. So we had a team of 5 to 6 interviewers, and they comprised nursing staff. We had the quarantine management unit at that time, so we used the staff from there as well. And we were lucky enough to have a colleague from the Red Cross who spoke Haitian Creole, and so she was able to translate the questions for that population. We used tablets to administer the questions. And we also mapped, so when the interviewer went, they would select the GPS point. So you basically ensure that they were where they're supposed to be in terms of taking the information. And we also used the OSM and offline maps to help navigate. And we also had a backup manual record just in case, because we know that technology, as we saw today, can fail. So, findings. We had a total of 207 households participating, and that equated to 304 eligible adults participating in this study. And even though we did not achieve the target population, I think that 304 is a significant amount of people to sample. Most of the respondents were Montessori born, and most of them were female at 58.2%. Males were older, with the median age being 54 years compared to women who were 48 years. So, look at this. Overall, 34.5% of the participants admitting to having at least one NCD. That's a third of participants. And if we were to extrapolate that to the population, that's a third. That's 1 in every 3 people has an NCD. And if you really think about it, everyone here, you know someone that has at least one NCD. So it's a significant problem. And it's just to show that, so anecdotally, we knew this, right? But now we actually have it in black and white, and we can use it to inform policy. So, and interestingly, of the 105 respondents, at least once 31 had 2 or more NCD diagnoses. Hypertension and diabetes dominated, and I just want to draw your attention that we actually found persons in the 18 to 29-year age group with diagnosis of NCDs. So that is significant, and it's showing that it's now creeping into that younger population. And you know, before we used to have, when I was in medical school, diabetes, hypertension, NCDs of that nature, cardiovascular disease, was often something that you would develop, you know, in your late 40s, early 50s, and now we're seeing that trend going downwards. And if you remember Dr. Hazel Blake's presentation earlier today, you can see that the younger population, they're developing the risk factors for NCDs. So it's something that we really need to pay attention to. Of interest, mental health. We looked at the tools for anxiety and depression with a severity score of greater than 3. That was recorded in 22 people that we sampled. And of interest, 7 women and 2 men had greater than 3, equal to or greater than 3 for both anxiety and depression. So we're now wondering, you know, is there some unmet need there for mental health? Also, looking at alcohol consumption, we found that 65.1% of participants recorded ever drinking. And, you know, I like to talk about St. Patrick's, and we're unique in that we are a Caribbean country that celebrates that. I remember one St. Patrick's celebration here. We were driving through, and every garbage bin was filled with beer bottles and that sort of thing. I think it was after a pub crawl that they had for that particular year. And again, anecdotally, we know that people drink. You know, we have a lot of bars on island and so on, but to see it in black and white, the percentage is striking. Of interest, men were twice as likely to have more risky behavior in terms of drinking, so they drank more often than women. And similarly with smoking, men were at increased risk of saying, you know, ever smoked regularly. only 41 people said that they ever smoked regularly, and only 16 said that they'd done so in the last 7 days. So when we look at smoking prevalence in Montserrat, it doesn't seem to be a major issue. However, when we asked about marijuana smoking, only 17 admitted to smoking with or without tobacco in terms of marijuana. And 5 people who were recorded as not regular smokers actually admitted to using marijuana weekly or daily. So it begs the question if people are actually considering smoking of marijuana smoking, right? Are they're thinking, is it something else? Because I smoke it, but am I really in the category of smokers? Culturally, we think of smoking as smoking tobacco. So we have to think about that in terms of our messaging. So challenges and limitations. We had a very short turnaround time to achieve this, but we did it. Observance of COVID-19 protocols, that was particularly difficult, but we're the Ministry of Health. So we were able to navigate that. Technology, we did have some issues with the tablets and the GIS mapping and so on, but we survived that. The interviewers, they came upon a lot of abandoned houses. And I know that, so since the volcanic crisis, we would have had a lot of the houses being abandoned, especially in the Salem, Alveston, Old Town area. But they also found abandoned houses on the more northern end of the island. So it may mean that when we're doing like the census or something, if we can look at, the occupancy rate of the buildings that we have. Another issue that I know we had was that the GPS or even the GIS system. So you would think that the building that's there is a dwelling house, but when you actually go there, it was like a cattle shed or something. So those are, little things that we have to navigate for future studies. We had a higher than anticipated refusal rate from eligible adults, which did not allow us to reach our target sample. And we think maybe it was a mixture of maybe research fatigue. So persons being asked to participate in studies over and over and over again, sometimes they're like, listen, I'm tired of this. I don't want to answer any more questions. Just leave me alone. Also, it could be because it was a health-related study. Some people tend not to want to divulge information about that. We do have a small population, so we have to be mindful of that. Also, we were wondering about underreporting for certain aspects, so like the marijuana use. Because it's illegal, were people honest in terms of giving us information about their use? And also stigma. So there's still some stigma around mental health. There is a bit of stigma around smoking, and there is stigma around diabetes and hypertension still. So there are some persons who don't want to admit that they have these conditions. So we wondered to what extent that would have affected the results. And the older age group, and I guess that is just reflective of our aging population. But what is good is that we still manage to pick things up in the younger population. So we just need to do further studies on that. So recommendations, always more research. So this was our way of at least getting some estimate of the prevalence of NCDs and the risk factors that contribute to that in our population, and I think we met that objective. But there's more that can be done. We need to investigate mental health a little bit more to see what's happening there, and also qualitative research, because maybe, and as Dr. Tiffany Skerritt suggested, the focus groups and that sort of medium, you might be able to extract more information from that. And the next steps would include adoption and application by ourselves, the Ministry of Health. And so just to let you know, in terms of the application of this study and all of the other studies that you would have seen today, we've started looking at our NCD gap analysis, again with the assistance of UKHSA,
looking at where we need to work on the priorities that we need to set, and that is supposed to feed into the development of our national NCD policy. So that will be worked on this financial year. And ladies and gentlemen, that is it. Thank you very much.
Any questions for our CMO on the household survey and her presentation this afternoon? The microphone is ready to go. So just as always, indicate by a hand if you have something that you would like to say.
Want to go home now? There's a question.
In your presentation, back up, it was a good presentation. My thing is women who have more than one, or in the survey, you found that women. But my thinking is that, is it that men are not the ones who would readily come and say that they have something, or ask you to check? They only appear when something happens. So in the survey, I think that is what happened here.
Mm-hmm.
So we need to look at our whole system as to how we can target men into getting them more proactive in taking care of themselves. Because there are times when you find that when men come, sometimes it is too late.
Mm-hmm.
And there's nothing that we can humanly do for them. So we need to look at the whole thing of looking at men and how can we get them to come.
Yep, I completely agree. And one of the things that we want to do at some point is repeat the survey, but we are wondering how we can incorporate it into something like the census, for example. So to have the same questions be repeated in the census, which I think is coming up soon, and we're hoping that we can have better responses then, because persons are more likely to respond in the census, and then they will give the health information. But we also need to look at the ratio of men to women in the population. We think that the study was representative of the population, but you know, we didn't meet our target. It's still a small number, right? So it's just it's an estimate, and it's the best that we have at this point in time, and it's just like a stepping stone to do even more research. So when we put this study together, and also you look at the hospital utilization rates that Abby would have presented on, and then of course you look at the risk factors and other issues happening in the clinics, and then the school health assessment, you basically have a good picture of what's happening in the population, essentially from cradle to grave. So that would be my response to that.
Yes, same. Another interesting presentation. I'm keen on the mental health aspect because, well, I worked as a district nurse for years and into public health. And the persons, they are so frustrated. They're so frustrated in that some admit to taking the medication as prescribed, and then when they come, there's a high reading, there's no change in their cholesterol levels, and you can see that when they leave from the health center, instead of feeling good, they're disturbed. One lady told me in one instance, "Nurse, I'm actually starving myself. Oh. I'm not using any butter, I'm not using any this, I'm not using any that, and look at this. I'm literally starving myself, I might as well go and just eat." So it shows the need for persons with chronic illness, diabetes, and hypertension to be able to have access to counseling and support to help to protect their mental health. No wonder why some of them are complaining about, admitting to anxiety and depression.
So what's interesting, thank you very much, Sister Silka. What's interesting though is that this So this did not look at the number of persons with diabetes and hypertension with mental health issues. The mental health numbers that you're seeing there are just across the board. So whether or not they would have had is general prevalence.
Right, but
I take your point that yes, we need to incorporate that into the management of persons with NCDs. It's important, and mental health is an NCD.
Support, yes.
Any further questions or comments? It doesn't appear that way, so thank you.
So ladies and gentlemen, we've reached the end of our research day. Can we have a much bigger round of applause for our presenters? And just to thank you all for being a wonderful audience, for sticking with me through power outages and problems with technology and whatnot. It's been great. I look forward to seeing you again for next year, Research Day 2024. And I'll now hand you over to Dr. Dorothea Hazel Blake to close us off and send us on our way.
Don't worry, it won't be long. Folks, first of all, I want to say a big thank you to all of you for being here. But I need to ask you two questions. I know some people seem to think we'll be here next year. What say the rest of you? Do you think we need to be here next year? Yes. All right. I'm sounding like the speaker. Are there any nays? I think the ayes have it. The ayes have it. Now, so that's good. That's one. And two, will we be having more presenters next year? So I can actually start looking for some gifts, maybe for the first, the new presenters and people like that? All right, so that's an incentive. Wonderful. But folks, those in the room and those of us joining us, the evidence is clear. The evidence has spoken loudly and clearly. There are things that we need to address. There are opportunities, I want to call them. When you do a SWOT, you look at your, certain things. I always look out for the opportunities, and there are opportunities here. The opportunity to address, as the CMO said, the issues we have with our children and their weight, because excess weight is a risk factor. There are opportunities to address the reasons people are being admitted to hospital, because people are being admitted for specific things, and the length of stay is clearly linked to what they're being admitted for. There are opportunities to look at the prevalence in our society, because we are the adults in the society. We are the ones who want to live long, healthy lives. And so, CMO already mentioned, I was going to say the way forward, one of the things we're doing, the ministry has to produce an NCD policy, which I'm hearing is in my PDA. So, for those who don't know, that is your performance measure. It's supposed to be in my PDA, so it has to get done. But I cannot do this alone. So when I come knocking at many of your doors, I expect and I anticipate the help. And I want to end then by wishing you a good afternoon and saying special thank you, though, to part of my team. You know who my team is, right? You know I have Team Awesome in primary health care. I make no secret of this all through COVID. I have Team Awesome. And sometimes the entire team works, sometimes portions of that team works. And so the section of Team Awesome who made all of this happen is Abby, who's sitting over here. Can I give her a round of applause, please? Aurel, who's standing at the back. And our facilitator for the day, Penny. Can I give her a round of applause, please? And I just want to take the opportunity to say a special welcome to two of our colleagues who are sitting with us today. They came in around midday. There's John, whose surname I've forgotten. John Lee. I mean, who could I forget Lee? John is offering support with the laboratory. Those of us who've been around would have seen John several times. He was here when we were training for the COVID testing and all of this. This is Mr. Laboratory if you want to have things done. And he came in to do the training back then when we were going to do PCR and all of that, and he's back now for additional training with other things. And then this gentleman who I met last year for the first time, he has come to us all the way from St. Helena. And of your name I've just forgotten, Jeff. Jeff could tell us, he's also a laboratory specialist. He works with the laboratory setting. He'll be around doing some work with Kimona, and Zara and the other ladies in the laboratory, doing some additional training, and because we've got new equipment again and as we advance. So welcome to both of you. I'm happy you were able to join us, and I hope you found the afternoon enlightening. So good afternoon and drive home.